Okay, I've just had a notice to say streaming is turned on.
Okay, and it's just come through here. So good morning, Chair. I can confirm that we are now live.
Thank you, Tom, and welcome everybody to our two boards in common. Just to explain, so this is the board meeting for NHS Coventry and Warwickshire Integrated Care Board and for NHS Herefordshire and Worcestershire Integrated Care Board. It's our board meeting in common. It's our first meeting together as two boards. And as for members of the public, the two boards have agreed to work together and meet as boards in common. We will each retain our statutory accountability and will make separate but aligned decisions wherever possible. And any members of the public looking at our documentation will note there are some colleagues around the board table who are joint roles and others who represent particular places and individual systems. Hopefully that's clear, but welcome to everybody as it's our first board in common. And I particularly also wanted to welcome Gail Quinton. Gail is joining the board for the first time. Other colleagues I know have been around the board table in various other guises, so but I particularly wanted to welcome Gail this morning as a new non-executive jointly to both boards. I also want to take the opportunity really just to recognise that there are a lot of pressures out there for our staff, and I just want to recognise and say thank you to all our staff who have gone above and beyond during this period so far, and no doubt will do so in the coming weeks whilst pressures remain ongoing. We have received apologies from Gill Nobbs, who's one of our non-executives associate, also from Simon Adams from Healthwatch Worcestershire, but welcome to Don Beckett, who's I can see on screen. And other than that, I think also maybe a couple of colleagues need to leave a little bit early today, but I think we are quorate, so we will formally begin the meeting. Can I just check before we proceed that obviously declarations of interest are recorded on our governance log, but is there anything that members want to declare at this point which is specific to the agenda today? Take that as none. Thank you. And looking then at the governance log, which includes the board forward plan, we have one open action from the Herefordshire and Worcestershire board in November, but that's not due till July, so we'll pick that up then. Other than that, Hannah, I don't think there's anything outstanding. Is there anything you wanted to draw to our attention?
Thank you, Chair. I think you've covered everything. Thank you.
Lovely, thank you. And just to mention, for people new to watching the board or indeed participating in the board, we always have a theme running through our board meetings. Today's theme is neighbourhood health, so I think we'll be getting some interesting reflections on that and a story related to that. In March, the plan at the moment, I think, is maternity and neonatal services, and I thought it was worth highlighting that because I know there's quite a lot of focus on that around the media, and so useful to highlight that that's currently what's on the plan. Hannah, I'm assuming that hasn't changed, but I think that would be a welcome update.
Right, it hasn't changed, Krishni.
Great, thank you. So we have minutes from our previous meetings, which were two separate meetings on the 19th of November. So first of all, can I just ask for the approval for the Coventry and Warwickshire ICB minutes, please, from colleagues who were present? I can see nods there, so I'll take that as approved. And then secondly, for the Herefordshire and Worcestershire ICB minutes, also from that date. Can I check that everyone's happy with those? Great, thank you very much. So we'll approve those and we will move on then to our patient and public voice section of our agenda. We don't have any questions from the public today, I believe, but we do welcome questions from members of the public, and people can check our website to see how you do that. So please feel free to do that in the future. So we'll move straight on to our patient story then, and over to Dr. Catherine Cobain. Kath, over to you.
Thank you, Chair, and good morning, colleagues. Before I share a short patient story, I wanted to briefly explain why we're starting here. As this is the first Boards in Common meeting of the cluster, it felt important to ground our discussion in the experience of the people we are here to serve. Patient stories help us to see how our system is working in real life. A recent independent review of patient safety by Dr. Penny Dash highlighted the risk of boards focusing heavily on metrics and assurance and losing sight of what care actually feels like for patients, particularly those who move between multiple services. Patient experience helps us see where care joins up well and where it doesn't. It helps us learn and improve, not just assure ourselves. The story I'm about to share isn't unusual. That's exactly why it's important. Ted is a 64-year-old man who lives alone and manages several long-term health conditions. Over time, he became known to a wide range of services: his GP, community nursing, social care, and specialist outpatient teams. Each service was responding appropriately to a particular need, but no one had a full picture of Ted's situation or what mattered most to him. From Ted's perspective, his care felt fragmented and overwhelming. He was contacted frequently by different professionals, often asked the same questions, and attended multiple appointments that weren't always well coordinated. When his circumstances changed, he wasn't sure who to contact. He described feeling frustrated and anxious, and at times felt he was carrying the responsibility of joining the system up himself. From a system point of view, there were consequences too. Information wasn't always shared in a timely way. Decisions were made in isolation. Effort was duplicated, and there was real risk that deterioration or wider concerns could be missed. Not because people didn't care, but because the system was organised around individual services rather than around the person. Ted is exactly the kind of individual that the Coventry neighbourhood model is designed to support. Utilising this, his situation was discussed at the neighbourhood multidisciplinary team meeting, bringing together health, community and social care colleagues. For the first time, professionals were able to step back and look at Ted as a whole person rather than through individual pathways. Information was shared, priorities were agreed, and a single coordinated plan developed. One named professional was identified as Ted's main point of contact, providing continuity, coordinating support, and making sure responsibility for oversight was clear. The impact was tangible. Ted now had fewer, more purposeful contacts with services. His care was better coordinated, duplication had reduced, and professionals are clearer about roles. Most importantly, Ted feels reassured. He knows who to contact, feels listened to, and experiences his care as being organised around him rather than having to navigate the system on his own. As Boards in Common, Ted's story shows why integration at neighbourhood level really matters. It's not just about structural ambition, but a patient safety and quality imperative. It shows how joining up care improves experience, reduces risk, and enables our workforce to work more effectively together. As we move forward as a cluster, it's the kind of experience we should continue to test against our decisions against, and we look forward to later on the spotlight, as the Chair mentioned, on neighbourhood health. Thank you.
Thank you, Kath. Would anyone like to comment or pose any questions regarding that story? Vicky, please.
Thank you, Kath. I mean, it's such a good story, as you said, along the theme that we've got today in the board. But I guess the most important thing for this patient was the communication, the feeling of coordination and reduced anxiety. And that's what we need to hold to us when we listen to the spotlight and as we go forward as a cluster, because that communication is so important, isn't it? So thank you for the story. It really helps set the context.
Thank you, Vicky. Anybody else? Simon?
Yeah, I'd just add, I think it's important context setting. It is designed to reflect just how important neighbourhood health is to our wider strategies moving forward. I mean, if there is anything that underpins the 10-year plan, but probably more importantly for us in these 2 ICB areas, our future strategies, we're building everything around neighbourhood health, aren't we? And I think the other interesting bit about the story that's worth reflecting on is, I think we accept and we acknowledge neighbourhood health won't look exactly the same in each of our 4 areas. We have 4 very different sets of populations with 4 very different needs. And if we're honest, we have 4 different ways of organising services in those areas. So our ability to understand, firstly, the importance and relevance of this, but secondly, the need to be adaptable, flexible, and probably embrace the difference is going to be really important as in terms of this wider strategy. So the patient story is important in setting that context, but it's probably those wider reflections around how much this underpins our strategy and just how we're going to have to embrace a different approach in each of the 4 areas. That's worth just putting on record, Christian, I think, for the board point of view.
Thanks, Simon, and I'm sure we'll pick that up as well when we come on to the spotlight item. Andy, please.
Yeah, thanks, Chair. Just building on Simon's comments, really. We talk about neighbourhood health as if it's a thing on its own, which is it's really important on its own, but actually it's how it fits into that broader system around, particularly around UEC. And I think that one of the things we're looking to do, particularly in Coventry, and as we just heard from a case study in Coventry, is thinking over these next 12 months as we look towards winter 26-27, how do we start to move towards a point where the majority of urgent care is actually scheduled? And you can start to do that by wrapping around certain patients, and we've just heard of a great example there. In Coventry, not unlike many other places, 7% of our patients account for 72% of our emergency admissions, both into health and social care. So trying to just wrap ourselves around those patients, identifying the next 7% can start to stop the demand or reduce the demand at the front door. And that's got to be how we start to think about the UEC challenge. Beyond the walls of the hospital, thinking about the front door of the hospital being in the community. I think that's what neighbourhood health is to us.
Yeah, really helpful. Thank you, Andy. Russell?
Slightly different point from me, Chair. Clearly an apology, which I know Kath has sort of indicated to the patient and their families, because it isn't a one-off situation where patients are having to repeat data time and time again, but also for our staff, the frustration of having to do that. And it just illustrates the enormous opportunities we have as we move to a more digitally informed world of stopping that duplication of staff effort and time. And we really need to ensure over the next few years, as we roll out more digital solutions to the problems we face, that the digital solutions talk to one another. So we stop the nonsense of having to put the same data in time and time again.
Yeah, thank you, Russell. Yeah, I mean, so much of this is linked to sort of how much more efficiently we could use our collective resources, isn't it? The digital solutions, the number of contacts with the patient that may not be actually adding value, and could be helping to avoid some of the challenges further down the line. So yeah, really helpful. Thank you. Chris, please.
Thank you. I think there's a link challenge for us as well, both as from a commissioning perspective and a provider perspective, and that is when we're looking at the older patients that we're treating, there is still a temptation for service models to adopt a curative mindset. And that can obviously lead to overprescription and things like this across specialties and subspecialties for the patient. And it's more difficult to have the conversation about managing something that might result in pain or discomfort or other compromises. But of course, sometimes it can be in the patient's interest. And so I think, this story does illustrate well the importance of taking a holistic approach to providing care, and it definitely has to be at the centre of our strategy.
Thank you, Chris. Finally, Gail.
Thank you. I think it's a comment that follows up from Andy's point. I think it's wonderful to hear that there's increased join up and communication. And my point is also the other end. It's not just about how that aids effective entry into health system, but it's how community, voluntary are kind of wrapped around a little bit more in order to work at prevention or mitigation, or people feeling that they're not isolated within their communities. So it's how it fits into kind of the whole spectrum, really.
Thank you, Gail, and I'm sure when we come on to the item, we'll explore some of these things a bit further, but I think really useful context for that discussion when we come to it. So thank you, Kath, for sharing that story. And as I say, we'll no doubt revisit Ted's example later. So we move on then to our strategic updates, which start with the Chief Executive Officer report. Before I do, I just want to also take the opportunity to welcome Vivek. Vivek, it's your first meeting joining the two ICBs together. So Vivek is from West Midlands Ambulance Service, and we've always had a bit of a sort of clearly important relationship with WMUS as our partner, but you've not hitherto been in a position to join us, so I just wanted to welcome you today. So thank you, Vivek, for joining. Okay, so now I shall hand over to Simon, please, for his report.
Thank you, Christian. Good morning, everybody. Just for the benefit of the audience, really, we'll try and have a report like this at the front of every agenda, because what it does is it hopefully sets the right context for the rest of the discussions we have, but also any items that we would try and usually bring for information, we'll try and wrap as much of that as we can into my report, so then we can keep the agenda shorter and more focused on the bigger issues. So the reports that you'll see are, they will be quite long at times, but they are designed to encompass all of the things that I think the board needs to be aware of in terms of the wider context. So hopefully people have had a chance to read the report. I'll just draw out a few things and then I'm very happy to take any questions. So firstly, on the top of page 2, we clarify the arrangement for the joint board. So lots of us have worked on boards in common and meetings in common and joint meetings previously. It's good to be clear just how this is going to function. It's obviously a clear part of how we drive efficiency and reduce our running costs over the coming months. I think we've done a really good job. I'm really pleased with how we've set this up so far, but it's the start of a journey, isn't it? So the report sets out the membership and the clear arrangements. Similarly, the ICBs are obviously having quite a journey internally, quite a change process, and page 2 of the report describes where we've got to on that journey in that process. I mean, critically and importantly, we now have a clear path to get down to the level of running cost reductions that we've been set. That path has been approved by NHS England and we're cracking on with it, really. There's obviously a lot of internal work involved in that. We're very keen that we continue to treat people properly with dignity and respect. There will be a number of people leaving the ICBs over the coming months. It's important that we manage that properly. But from an external point of view, our focus is on the day job, really, and making sure we have the right people doing the right things to keep driving forward the development and the commissioning of services across these two ICBs. The report gives the headlines of that. It's worth reflecting. Pages 2 to 5 then give some headlines of some work we're going to start doing across both the boards, just on our wider strategy. So this is largely to inform our 5-year commissioning plan as part of the planning process, but probably more importantly for the two boards, these are the things we're going to commit to. And you'll see the early work we've got, which is focused around 4 shifts, so 3 shifts in the 10-year plan, but a more local shift to strategic commissioning to supplement that, and then 6 building blocks that define the main areas of work that I think we need to be focused on. Christian, we've talked about, we're going to spend some board development time next month on just getting underneath the skin of this and getting everybody's input, so this becomes a shared and jointly owned strategy across the two ICBs. We do have more detailed finance and quality and performance reports later on the agenda, but I will always aim to give the headlines. I think in general, as we talked about earlier this month at the board development session, performance in our patch, it's not perfect, but we've actually made some quite good progress in most areas this year. And I'd pay credit really to the teams of people that are driving the reductions in the waiting lists, the elective care targets we have, the improvements in cancer, and the management of the urgent care system through what's been a particularly difficult period, particularly that 6 weeks before Christmas, I think was particularly challenging. So credit to the trusts and their teams for the work they've done. And we highlight actually an example from Coventry again on the work, some of the work that's happened to reduce A&E attendances from patients in care homes. Now I do that deliberately just to not to highlight Coventry, but just to emphasise the focus at local level, which is often on what are the things that are causing us a problem, and then how can we corral efforts locally to get everybody focused on a joint solution. And I think the care home patients example is a great example of, you know, locally bottom-up initiatives that are making a real impact. And you can see from the graphs, I know they're very small in the report, but you can see the trajectory and direction of travel on both of the graphs for care home attendances at E and A&E. And again, I think that should give us confidence that the approaches we're taking will have an impact over the longer term. And then finally, Krishna, I think page 9, which is important to draw out. So the NOF metrics, the National Oversight Framework, which all of the trusts are involved in the first set of assessments, we had 4 of our 7 trusts were rated at NOF level 4. So obviously significant room for improvement. But importantly, and actually pleasingly, 3 of those 4 trusts have now moved to NOF level 3. So it's important we continue that improvement. It's important we're now looking to get into the higher segmentations. And it's important actually we work together to support each other, continue that journey. So, you know, we want to all succeed together or all fail together, don't we, in this sense? Those oversight framework ratings, whatever the whys and wherefores of the science, they are important public optics as to how things are going. It's really important as a board, I think we retain that helicopter overview of the direction of travel. So Krishna, I'll probably stop there, but I'm very happy to take any questions.
Thanks, Simon. So over to colleagues, if you'd like to come in and ask Simon any questions or make any comments regarding any part of the report. Suki, please.
Thanks, Simon, for the comprehensive report. I've got 2 questions, if that's okay. What challenges does the variation in place structures across the cluster create for effective system working, do you think?
I mean, it creates a lot of challenges, doesn't it? What we've got to work through is where we need to maximise benefits from economies of scale and where we do need to work differently. As I said earlier in the patient story, we have 4 very different collections of communities that we serve. I think even my experience, even when you look at a place like Warwickshire is a collection of different communities with very different needs. Actually, parts of Warwickshire are very different to other parts of Warwickshire. And it's where neighbourhood health is important, I think, that we've got to allow sufficient flexibility for local initiative and collective action that meets the local needs. So we're trying to balance that with the things that we know we need to do at scale and where we can benefit, and that will always be a feature of a strategic organisation, won't it? How do you get the right strategy, but how do you free up the parts of the delivery where people are able to grasp the initiative and to do local initiatives? So that's going to be, I think, just an ongoing dilemma and conundrum for us. But I'm pretty confident that we can come up with an operating model that strikes that right balance. I suspect, Suki, at every board meeting to come, we'll be talking about aspects of striking that balance. So a really good question, I think, to highlight that challenge that we're going to have. But I'm confident we can meet that.
My second question is that we've gone through quite significant sort of change as an organisation. Which elements of the transformation programme are progressing with a higher tolerance of risk, and where does the executive sort of seek the board's guidance on risk appetite?
Yeah, again, very good question. I think we'll hopefully get into a bit more of that in the strategy development work, so that there are risks across all areas. I mean, the most significant risk we are all managing is resourcing, isn't it, and financing, and it's working out where to prioritise the allocation of resources. There will never be enough money to do everything to the extent that we want to do it at the same time. So our decision as executive leaders and our collective responsibility as this board is to make the right decisions around prioritisation of resources. That's where I suspect the crunchiest conversations will come. But look, I think we need to go on a journey with the development of this strategy. It needs to be something we all own. I want people to feel like they've been able to contribute, and it is a board strategy. It isn't just something that we've kind of magicked up in a dark room. So I'm thinking as well, I don't think it's something we're just going to quickly finish. We'll have a product that will suit the national planning processes and will meet the requirements of a 5-year commissioning plan. But I see strategy development as an ongoing process, to be honest. It needs to be iterative, it needs to evolve, doesn't it, over the coming months. So I don't think there will be a fixed point where we say, right, that's it, that's our strategy, we're not changing. I think the world we live in will require us to continue to evolve that. So hopefully that answers your question.
Thank you.
Thank you, Suki. And probably worth saying, I don't know whether we can cover this in February, and I'm sort of looking to Hannah here, but when we're talking about the strategy and agreeing our sort of key strategic objectives, you know, we will need to at some point revisit our risk appetite collectively, won't we, Hannah? And I'm imagining that we've got some thoughts about when we'll need to do that. So I think there's a whole piece around risk that we will need to come back to, because we're bringing two organisations together to think about that. So I don't know, Hannah, if you wanted to add anything to that.
No, thank you, Krishna. I was going to mention this as part of the board assurance framework item. So absolutely, it is a key part of strategy setting, and I will be speaking to David Mahaffey about building risk appetite setting into the session in February, because it does make sense to address them both together in order to be able to set our joint objectives for the next business year.
Great, thank you, Hannah. Okay, David, please, David Whiteman.
Thanks, Krishna. And Simon, a couple of these questions, a number of questions, but some of them also come from Aman, who's given them to me to ask on her behalf. But first, I wanted to say, and it kind of comes to one of the points that Russell has just been making in the chat. You know, congratulations on mapping out that path to the cost framework that we need within the ICB. I know that's been really difficult, but I think you and the executives, and indeed the whole of the team within the ICB, have made a great progress on that. So congratulations on that. And secondly, when talking about finance, I want to make the point that and I think we as a board too, probably strongly support creating an investment pot, which you mention in that report, which we can then use to allow the systems to make real progress rather than simply fighting day-to-day priorities. So I think we're all in support of that. There are a couple of questions really from Aman about the reduction in A&E attendance coming out of the care homes in Coventry. I think that's a really, really encouraging sign. And the question is that scalable? Is it clear what we would be able to do yet to roll that out across different geographies? Again, another point that Russell was making. And then similarly, is it clear in terms of cancer what actions Worcester Acute and Wye Valley are taking which will likely to have the highest impact? Those would be two questions as well from Aman.
Yeah, and I'll start with those, David. I mean, there always are things that are scalable to when you do projects and initiatives like the Coventry Care Home thing. The point is, though, it's more about embracing local ownership and freeing people up to focus on this. As Andy said, this is all about identifying a cohort of vulnerable patients, be it in care homes or at home or regular attendees at GPs or people with long-term conditions, and the collective clinical conversations at local level around interventions that we can offer as a wider NHS health and care system. So that's what the Coventry thing is more about. And I'd hope that's what's scalable actually, is the cultural mindset approach. There will be things that you can think about, and I'm sure in each of our areas. Work will be going on today on how do we support patients in care homes better and avoid their need to go into the hospital system, because actually we should be much better at having scheduled urgent care management plans for people in care homes, because we know exactly who they are and we know exactly where they are at most parts of the day. So the point is more about what's scalable is the mindset and approach at local level rather than really any particular initiative. I mean, on cancer, I'd probably see if Stephen or Mary wanted to come in around the specifics. I mean, we've been on quite a journey with cancer performance, quite a decent journey, successful journey in Worcestershire Acute Trust and Wye Valley. But Mary, do you want to add any points of detail around the specifics?
Yeah, so cancer demand or referrals have definitely increased. That is one of the biggest aspects of this. But the best practice time pathways, we're still working on some of those to fully roll them out, and getting extra capacity in to meet that demand while this while the extra referrals have come in. We are working through the tiering process with the region and the national team, and I know there's some concerns at the moment about the next couple of months. Stephen might want to come in on that, particularly in Worcestershire, as to where we're going to sit. But you know, I can see a route through to recovery. It's just making sure that each month we hit the targets that have been set.
Stephen, do you want to add anything?
Yeah, I mean, particularly in Worcestershire, we're particularly focused on, there are a couple of pathways that provide the biggest number that will drive the biggest improvement, so urology and dermatology. We've undergone quite a significant service change in dermatology, bringing in, building the service back up from where it was a couple of years ago. So that's really on a route to improvement, and the reason you probably don't see it straight off is we are working through that backlog. So as we do that, we will start. So the performance dips as you get through the backlog and then you come out. One of the principles we've been dealing with across both Wye and Worcestershire, a couple of things. One is there's much better conversations between the two trusts. Obviously, I've got a role that I've been playing alongside where Glenn was leading it, of them working together and looking how they support each other. So you'll start to see collectively better performance across the two. And the other thing, particularly from a Wye Valley point of view, but increasingly with Worcester, we're doing some really good work with Gloucestershire as well. So we've got Gloucestershire Acute Trust. So we've really put the building blocks in place that what you should stop seeing is an improvement, then a drop again, an improvement and a drop, and it's not sustainable. The whole principle's been we've got to deal with it and be sustainable on that.
Great, thank you. I think that helps answer David's questions and Aman's as well that came in as part of that. So over to Rachel, please. Rachel Hardy.
Thank you for the report, Simon. I noticed I wanted to make a comment about the emerging cluster strategy, and we've also talked about the medium-term planning submission that you've got to make in February. Looking forward to the conversations about the emerging cluster strategy at our next board meeting, but I want to make sure that the planning submissions that we always churn out every year don't become a separate thing from our strategy that we're developing, and that what we're talking about as a strategy actually reflects in what we're saying about each organisation within the patch. And maybe you can comment on that now, or maybe that's something for how we develop that going forward whilst we're developing the strategy.
Rachel, I think that's a really good point, and we must continue to challenge ourselves. So the kind of filling in the returns and feeding the national system to allow it to have the information it requires absolutely has to align with what we want to do. And we talk a lot, don't we, about left shift being one of the 4 shifts that we're focused on. So left shift in practice means in those returns will show that we will be planning to spend less money on acute care and more money out of the hospital in some of the community services and general practice. So I think we should keep testing ourselves. There are some very simple tests around that we must keep applying. Of course, there are complexities. When we look at reducing the spend in acute care, we are dealing with quite a big waiting list and some quite ambitious national waiting list reduction targets. So it isn't as pure as saying it must be less, but we are going to have to make sure that in our strategy work, that does align to the planning. So I totally agree, Rachel, and let's keep coming back to that. And I hope one of the conversations we can get into in the board development session next month is the practicality of making that happen from a finance strategy point of view, as much as an organisational strategy point of view.
Thank you. Thanks, Simon. And thanks for the point, Rachel. Mary, please.
Thank you, Chair. Simon, I just wanted to comment on the segmentation levels, so North 4, because CWPT being the only organisation that's still in North 4, that feels uncomfortable for us as an organisation. If I put my organisational hat on, I think it's worth just commenting on the fact that in the last segment, we've moved from 51 out of 61 comparator trusts to 49 out of 61. We understand there are two areas that are particularly driving our position in this. We are about to move to a new electronic patient record on Tuesday, all being well. That's going to provide us some great opportunities to be able to report on our actual performance, because we understand two of those areas are because we are not able to extract the data in an accurate way. So you have a mismatch between the data that's presented nationally and actually what the reality for our patients is on the ground and for our staff who are trying to provide that. I just felt it important to sort of give a bit of background in terms of where we are and where we would hope to get to, because that would be an area of concern, I'm sure, for members of the public who see CWT's performance and as such.
Thank you, Mary. Really helpful. I mean, actually, I was just going to make a general point. So perhaps on the back of Mary's point, I wonder if, Simon, when we do kind of an update on this on the next iteration of segmentation, it might be helpful, and I'm sure, you know, this is something that the boards of the relevant trusts would also want to consider. I think it's really important for our stakeholders and our patients to understand what it actually means, and that doesn't mean we should go into a lot of detail, but Mary's context there I think is really helpful. So I do wonder whether we should just say a little bit more about whether in some instances being in segment 3, you know, is because of a financial override, you know, what are the kind of key elements of performance that contribute to, without going into loads and loads of detail that are not helpful. I think for members of the public, it would be useful to understand whether what's driving the segmentation. So I wonder if in the future we could say a little bit more about that without going into, as I say, a huge amount of detail. But I do think it's helpful because the financial override does maybe also kind of change, you know, I suppose masking performance, if I can say that. So members of the public may not be absolutely clear whether it's for financial reasons or whether there are other factors in terms of waiting list, for example. Would that be okay, Simon, if we could pick this up?
That's a really good idea, Krishna, because it's all about context, isn't it? Most things we talk about, it's about the wider context. And Mary, I'd just make the point to wish you good luck with the EPR implementation. There are people on the call from trusts that have been on that journey. We've got other trusts that are to follow you on that journey. I think we all recognise what a significant undertaking operationally that is, actually. So we wish you good luck with it. And obviously we're all keen and eager to help in any way that we can to make that a success. But, you know, good point, Christian. Context is important, I think.
Thanks, Simon, and thanks, Mary. I think also I remember in a passing conversation with Eamon, I think, you know, one of the potential benefits really of EPR, I know, or electronic patient record systems, is where it brings greater interoperability, which I think is the phrase that's oft used in the NHS, but it's basically for members of the public when systems are able to talk to each other, and that means partners can appropriately share data, which helps. I think one of the key things, and Russell mentioned this at the beginning, I think, that, you know, people don't want to keep having to tell us their story, and it's not a helpful thing to ask people to do constantly. So where it's appropriate to share information in a managed and properly governed way, I think that can be really helpful for everybody and make things more efficient. So I think, as I understand it, the system that CWPT are planning to put in will help with that as well. So that's a positive, hopefully, too. Beej, please.
I think my question's been broadly answered, Chair. Thank you. But perhaps I take the opportunity whilst I've got the mic to just also offer my congratulations to Simon and the wider team. I think for the pace and effectiveness of delivering the cluster board and the areas of focus. So well done for that. You've clearly had to make some very difficult decisions. They've been made with professionalism, with maturity. So it's worthy of note. So thank you.
Thank you, Beej. Thank you for sharing that. Pete.
Thank you, Chair. So first question, Simon, as you move through the next stage of organisational change, please can we find a space for at least a conversation on any inter-organisational impact and therefore system impact associated with what you may be considering or may have to do, so we go into anything eyes open, and that'd be very appreciated. And secondly, your comments, I absolutely agree with your comments around scalability and transferability of the care homes work in Coventry, and maybe what we're trying to scale up is the mindset on improvement, which leads me towards perhaps we need to consider as a system our approach to workforce development as a result of this change, because inevitably will require different things from our teams, which will include a different way to manage and perceive risk in their own roles, and therefore how we manage risk as a system. So I feel we've got a reasonably intelligent workforce development conversation to have somewhere along this journey.
Two really good points, Pete. Of course, we need to keep talking about local organisational impact. There are lots of organisations who could be impacted by this, the changes we're making. My aim is that we provide as much continuity as we can, particularly for things that are working well. And that's, I do think, look, I appreciate people's comments about our internal organisational change process, but actually I am of the view I want us to start looking forward now. We've spent a lot of 2025 being a bit introspective within the organisations, agreeing to the cluster, appointing people, agreeing to a change process. We need to keep that process going, to keep doing it in the way we've done it, but we do need to be more kind of externally focused as well, I think, as an organisation. We'll definitely need to keep talking to local authority partners, to trust partners, and to everybody else in this room in particular, to make sure we're not making any decisions which have an unplanned or adverse impact. So Peter, absolutely accept that. And you're right about culture and workforce development. I think there's some really interesting conversations in the NHS about the development of commissioning knowledge and capacity, and that is really understanding those 4 stages of the commissioning cycle and just working out how we can get the right capacity and capability. I actually think there's some real joint relevance to that with local authority colleagues, because you can't be a really effective commissioner without understanding those areas where it's most effective to jointly commission. So I think there is a really important and interesting piece of workforce development around joint commissioning actually as well, which we should be doing with you and your 3 other colleagues actually. So let's keep that conversation going. I'm very happy to pursue that with you, Pete.
And it's perhaps a theme we should pick up in our discussions around strategy, really, because it's potentially an enabler, isn't it, Pete, to everything we want to do, I think. Sue, please.
Thank you, Chair, and thank you, Simon, for the report. I found it very helpful to read and almost felt like a mini manifesto at this point of the journey for us, so that was good. If I may, if I could just repeat something that I said at our development session a couple of weeks ago, and actually building on what Pete said just about risk, if we can keep that point there about really understanding system risks amongst us, I think that would be a good point to take forward. The other thing that I wanted to do, and I suspect Becky may come in on this as well, is endorsing what you say about the development workshops, particularly with health and wellbeing boards. It feels to me like there's a significant piece of work to do and keep doing there in terms of understanding of the importance of neighbourhood health. Engagement and understanding on neighbourhood health with all of those involved is going to be critical to its success. Thank you.
Yeah, Krishna, I would agree wholeheartedly. I mean, neighbourhood health will not work without the right focus on all of those wider determinants of health. So we talk a lot, don't we, that people's health and well-being, about 20% of it is to do with the quality of their local health services. 80% of it is to do with everything else that's happening around them, like the local economy and access to jobs, housing, exercise, diet, access to green space. So I see we've got to get the health and wellbeing boards properly involved and engaged in that. So that's what we need to be seeking to do. So I agree with you. I think there's quite a bit of opportunity and further development work we can do with all 4 health and wellbeing boards that are all a bit different, but I do think that's a big opportunity for us. So yeah, thank you for making that point.
Yeah, thank you, Sue. I mean, I was going to pick that up a little bit later anyway, so I'll just reinforce that. I think it's really important, that engagement, particularly as the integrated care partnership structure that we had previously in place is in effect, I think, being put to one side. So the role of our interaction and engagement with health and wellbeing boards on particularly in neighbourhood health and the wider determinants more generally, I think is really, really important. So a kind of shared investment in building our joint approaches, I think, will be really valuable. Thank you, Sue. Roy?
Sorry, put myself on mute. Thanks, Chair, and yeah, thanks, Simon, for the report. My question was about priorities. You talked about getting a sort of an idea of our priorities and a clinical view on some of the problems. And I guess looking at the care homes work, that's really interesting. But I guess there's a risk that we end up focusing on things that may not be a problem within our own systems. And as we move to a larger sort of ICB structure, some of the wider ICB issues may not be an issue for our local areas or particularly our neighbourhoods. And I guess it's sort of thinking about how do we make sure we're focusing on the right problems for our areas, and how do we make sure those are evidence-based? Because I think sometimes we focus on the problems where there's some noise, maybe around urgent care, and actually the issues for our system may be quite different. And as we move to the larger structure, where do we make those decisions? Is that at our sort of place partnerships or provider collaboratives, or is that at neighbourhoods? And where are we going to have the right discussions to make sure we're not going off on sort of rabbit holes that are affecting other parts of the system instead of what's really matters for our patients?
Yeah, good question, Roy, and I guess to the heart of the detail of the operating model, doesn't it, that we need to keep developing and evolving. So absolutely, and it's a good chance to reiterate that there are some things that are scalable, but actually trying to do the same thing in it all over the 2 ICBs and the 4 upper tier authorities and however many neighbourhoods we have, trying to do the same thing in all of them would be a huge mistake, because exactly as you described, Roy, some things are a particular problem in some areas and they're not in others because the problems are different. I think this gets to the heart of that bit of the commissioning cycle, which is population health management, and really having the proper understanding of the data and intelligence, which is highlighting where the main demands and opportunities are. And I think there is a debate to have, Roy, around place, i.e. upper tier authority, so Worcestershire in your case, and what Worcestershire is doing, and then what the neighbourhoods within Worcestershire are focused on. I think we need to work through the detail of precisely where responsibilities are going to lie. I mean, I don't think there's a black and white answer, to be honest, that says, yes, you'll do that at neighbourhoods, you'll do that at place, you'll do that at ICB, and you'll do that at clustered ICB. I think it's more complicated than that, but it does enable the conversation, because what we want to do is we want to do the right things at the right level, don't we? That's going to have the most impact. This is all about impact, isn't it? Everything we talk about, all of the actions we talk about taking, we're doing them because we want to have an impact. So there will be things, I have no doubt, that will be right to be prioritised and focused on at neighbourhood level. And next door neighbourhoods might be doing something different because those needs are different. But we'll only know that when we've developed our proper capacity and capability of that stage of the commissioning cycle. So I suspect this is going to be an ongoing conversation, actually, just how we get the right things at the right level in that wider operating model. But good to raise it, Roy, because I think it gets to the heart of some of the strategic debate that we'll be having over the coming months.
Yeah, thank you, Simon, and thanks, Roy, for raising that. I totally agree. I mean, I think we're going to need to keep coming back to this. What's the right thing to do at the right level, and is this relevant for every neighbourhood? And data is going to be really, really important. We know that, to help us with particularly the neighbourhood health work. Becky, last but not least.
Thanks, Krishni, and thanks, Simon. Really helpful and clear report. Building on Pete and Sue's point, on page 8, you outline the planning time frame. So we've got commissioning plans, provider plans, and the neighbourhood health plans, all to be drafted and submitted by the 12th. And I think we're still waiting for the guidance on neighbourhood health plans as well. So I suppose just wanted a view on how realistic is that, and will they go in at the expense of appropriate engagement, because as you say, there's lots of system implications for this work.
Really good point, Becky. So I think what we describe are really the next steps. I think we are expecting there to need to be further planning work in March. I've been involved in some of the national conversations actually about the neighbourhood health guidance and the Better Care Fund guidance, which I think they are planning to change reasonably significantly. But that becomes quite complicated, doesn't it, politically? So I think there are conversations that will still be ongoing. We'll just be as pragmatic as we can at local level. Engagement really matters. I mean, I think the evolution of the roles of the health and wellbeing boards is a particular thing that we're going to work on. We had your meeting last week in Warwickshire. I know we've got Coventry next month. There was a Worcestershire meeting yesterday, I think. So the role of the health and wellbeing boards is going to need to continue to evolve. I think there's a bit of that will be dictated by the guidance. And I think there's a lot of that actually that we can own ourselves. So I hope we can focus in our engagement on the things that we can own ourselves. But certainly from a planning point of view, February is one of the milestones. I'm expecting further milestones later in March, so it won't be hopefully all squashed in a rush. We've got a lot of work to do before the 12th of February, but that work's going to carry on, I suspect, through the rest of February and into March as well.
Okay, thank you very much. I think that was good opportunity just to talk about a range of different issues that were highlighted in Simon's report. There was nothing, I think, Simon, you wanted us to approve, so the report is just there for noting. And thank you everyone for questions and comments that you've made. We will no doubt pick up some of those as we go through the meeting, because there are some other reports that perhaps go into some of these areas a little bit more detail. So without any further ado, I will move on to item number 9, which is the spotlight on neighbourhood health. So this is a more detailed report on the work that's ongoing at the moment. Mary, I think in the interests of, I mean, we're doing fine for time, so no worries on that, but obviously people might have more questions to ask. So if I could ask you to do some sort of high level highlights, if you like, and then we can open it up. Thanks very much.
Thank you, Chair. So yeah, and the discussion has covered quite a bit of the report, so thank you, colleagues, that's really helpful. It's been incredibly interesting and helpful for us as a new cluster to pull this report together about neighbourhood health across Coventry, Warwickshire, Hereford and Worcestershire. It's given everybody who's been involved in pulling this together, including quite a few executives across the system, a real insight into what is happening in each area, the difference, the variation that we've talked about in the population and demography, and also some of the needs in those areas and some of the outcomes that are required. And to the conversation we've just had, one of the pieces of work coming out of this is benchmarking across the whole cluster now as to where we are, where we're doing well, where we don't need to focus, as Rory said, and where we do need to focus in each area. So that has been very helpful for us as a system. It does show, this report, the local ownership in each area each place-based system is really taking a lead as designing their integrated neighbourhood teams and neighbourhood health. How the differences in how we're using population health management and how we can what the next steps are to improve the outcomes that we need for neighbourhood health. So that's been very helpful as well. I was going to go through each of the areas, but we've picked up some of the positives that come out of this in Coventry. I'd just like to highlight one other area that I think is incredibly important. That's in Herefordshire, where one of the agreements is for some of the most complex individuals that required integrated care, a 1 hour face-to-face meeting with a lead clinician with an integrated neighbourhood team to set the plan once and positively gives us much more of a chance of meeting their need in their community rather than acute settings where that's unnecessary. So overall, some of the learning in this plan is, I think, just as putting this report together, we're sharing already across the system, and I know some of the places are talking now between them about what they've achieved and what they're doing, but it does show great variation as we've already discussed. What I'd like to sort of focus on is the national neighbourhood health plan. So just for members of the public, so to support delivery of neighbourhood health, which is a key aspect of the 10-year plan for the NHS, but as we know, it's not just the NHS, it's the whole system that needs to work together to support this. There's a large-scale change programme facilitated by the Department of Health and Social Care to gather and disseminate learning and support areas across the country to develop at some pace and share that learning with others. So after a sort of a process, 2 of the areas in our cluster, so that is Coventry and Herefordshire, were successful in being part of that national programme. It doesn't mean that we're not continuing the work in Worcestershire and Warwickshire. In fact, you know, it's working alongside them to continue that work, so that's really helpful. And Becky's right, we haven't received the national guidance as yet, although I've been in a meeting this week. It should be imminent, is what we're told. But you can see outlined on page 2 the foundational steps that we've got to put in place that aim to support that variation that we see sometimes in our systems, the local integrated care that we need to provide through integrated neighbourhood teams, and planning to reduce unnecessary urgent care attendances into the system, and help us to redesign elective care, all with the premise of making us more sustainable for the future, because we know with the different populations, particularly frailty is a big issue in our cluster, as is, you know, deprivation in some part of our systems. If we don't make those changes, sustainability is going to be very difficult. So each area has outlined for us their in-depth work that they're doing, and it's really great to see the passion and enthusiasm for it from each area, and we'll now foster across the cluster the learning as quickly as we possibly can, supported by the national team. And some of the national team have been down into our area to look at what's happening and reflected how important the passion and the work that they're doing is already making change. That's good. That's really good to see. What I'd just like to focus on is on the last page, really, how as a cluster that we can help and support, and what we need to provide to the place-based systems to improve their outcomes. This is a significant transformation programme. A lot of services have worked in the way they've worked now for many, many years. So the workforce development, I think that Pete mentioned, is so important for us to get right in our system. So we've highlighted about half a dozen areas we think we need to support. So integration and commitment to one model is with the capacity to undertake the change is significant. We know the day-to-day pressures don't allow a lot of time for professionals across the system to do the change management, and the workforce change and organisational development. We need to find a way across the cluster to support that at the pace that we need to help those multi-specialty teams work in a different way. Each partner needs to be treated as an equal partner across the voluntary and statutory services, indeed the communities that they're working in, and that is going to require organisational development as well to ensure success. So that's something that we're starting to discuss, and how that can be supported across the system as well. The infrastructure has been mentioned several times this morning already. So estates capacity, information technology, how these integrated neighbourhood teams work, and work successfully in an integrated way. We're fortunate there may be a bit of capital at the moment, so we're looking at how we can prioritise that for integrated neighbourhood teams. So but that is really important, so we can give those teams the opportunity to work in a way that does that integrated care. The workforce capacity within communities to identify those needs and be more proactive and preventative in a way they're not able to now. So the newly formed cluster, and this has already been mentioned, so in line with our commissioning intentions, we will develop a 3-year out of hospital investment resource that aligns to that financial planning framework and evidence of reduction in acute hospital spend. Now, we all know what a challenge this has been for the NHS for many, many years. We need to commission and provide in a different way to see the outcomes this time to make sure we deliver that outcome, but there will be some resource help in there to help us to move that in that way. And we will benchmark alongside that to make sure we're targeting that resource in the most effective way possible for the new cluster. We do need to change the contracting mechanisms that we've put in place related to neighbourhood health to ensure that capacity and capability is there to deliver and develop contracts if we're going to do that at the place-based level, and get everyone to accept the associated risks and maybe incentive frameworks that will have to be put in place alongside commissioning and contracting going forward. And that's obviously a different way of working for the whole system as well. So also staff and public engagement and education is really important in this large-scale transformation programme to ensure we see those effective changes, to explain mainly to the public but also to our staff what outcomes we're trying to achieve, why we're making changes, etc. One omission from this report, neighbourhood health is largely been focused nationally on adults, but children and people play a big part in neighbourhood health as well. And you know, we've spent a lot of time with parents of children with complex needs, and the duplication and reassessments in children's, I think, is even more prevalent than it is in adults. So we will be undertaking the same approach with children and young people to ensure we release time to care of the professionals to provide care and support, rather than the infrastructure providing us, filling in forms and writing assessments all the time. It's even more prevalent in children. So I'm happy to take any questions, but this is a sort of a stock take of where we are, waiting for that national guidance. I don't think it's going to change very much from what we've got in this paper unless there's something comes very left field to us. But it is a real opportunity for us, but we've got to meet the challenges in commissioning, the way we commission, the way we contract and the way we provide, and the way we foster those relationships at place and equal partnership to see the outcomes we need. Thank you.
Thank you, Mary. So we'll open it up for questions and comments. Mary, please.
Thanks, Mary, for that overview, really helpful. I guess you probably touched on the question that I was going to ask, which is the whole plan seems rather silent on children. So it was going to be, what sort of thoughts are we giving, especially noticing the rise in sort of demand for support for children and families, particularly children with neurodevelopmental needs that touch every bit of our systems, be it education, housing, you name it. So that was just going to be my point, but it sounds like it's the next phase of the thinking and the plan. So that's fine.
I can come back on that, Krishna, a little bit more if that's helpful. So,
yeah, please do.
We've been discussing this a lot with our partners around children, which is obviously includes education as well as social care communities. And there is a neighbourhood health model developing wrapped around schools. There's always obviously the early help as well that we need to provide, but wrapping around schools and how we can provide services more in schools where the child feels more comfortable often and there's a wealth of knowledge about the child. And if we could get one comprehensive, effective assessment for that child in school that meets all of the requirements, we're more likely to give the care that we need. We have many incidents of children getting to 15, 16, and they've got a plethora of assessments and have had no care and support. So that's the change that we need to make quite rapidly in our system and design it around neighbourhood help.
Thank you, Mary. Ellen, please.
Thanks, Chair. I've actually got 2 questions just to flag that at the outset, 2 for the price of 1, if that's okay. And thanks, Mary, for the report. I found it really helpful actually to see all of the neighbourhood health work pulled together in one place. So I think that's been enormously valuable, even though you did have to sort of wrestle it down into one thing. Thank you for the work you've done. So my 2 questions are sort of on quite different areas actually. So the first one I wanted to just ask was around benefits realisation and core metrics. So I think as you've gone through the different case studies, we can see metrics that different parts of the system, the cluster, have identified for measuring. And I guess the challenge when you pull that up to the cluster level is how will we have some and agree some kind of sentinel metrics to get some objective analysis of where our models are perhaps more or less successful, because if the cluster will add value, that is exactly the point for me where it could add value. Because of course, if I put my place hat on, I'll be interested in having some local control around that. But I think it's really important we do some of that pull up, sense making and challenge back so we can get the best practice truly shared across the cluster. And my second point really is around voluntary sector organisations. So I think there's quite a lot of reference, potentially / assumption about participation of voluntary sector in neighbourhood health. So I guess my second question is about how organisations will be supported to participate sustainably, because we've got a very variable position in terms of funding and capacity. Thanks.
Thank you, Ellen. Really helpful questions. We had exactly the same discussion about how we measure this at a cluster level in the recent days, to be honest. And I think that's a piece of work that we all need to be involved in. I think a lot of the metrics and benefits need to be owned by place and designed by place to meet that local need. We need to now, our next stage is to look at which of those, I don't know, half a dozen key areas across the cluster that we need to oversee and maybe influence and monitor. So that is the next stage for us now. We're in a newly formed cluster, and the commissioning cycle will help us to do this as well, that we're going to be going through. So let's watch this space on that one, Ellen, but it's really helpful to have that outlined. Yeah, the voluntary sector organisation, that is an interesting one, isn't it? So obviously, every place has got very different commissioning arrangements, very different support arrangements through both the NHS and the councils in those areas. I think we need to scope all of that and see again, understand what it is like across the cluster, and then through our commissioning models and frameworks, see what else we can do to help support the voluntary sector to be involved and to be present. I think there's going to be a debate in each place, I think, so we'll welcome that input from place into how that would work as well.
Thank you. And just really, because they were things that I was going to highlight as well, so I will just take the opportunity to reinforce, I think, what Ellen said, that I do think it's really important that whilst we understand that there will be differences and variation, there needs to be something that allows, if we're a strategic commissioner of these models, to really understand at a core level how we're going to kind of evaluate the success of the approaches we're taking. So I do think that kind of core sense of how we measure that is going to be important, but also the voluntary sector. I think it's really important that we see that as I think it's potentially a missed opportunity if we don't see the voluntary sector as a kind of community assets that can support us with this. Neighbourhood health without voluntary and community sector isn't really neighbourhood health at all, it seems to me. So how we engage, I think, with our partners to do that and create sustainable models which involve them and in an integrated way, I think is really important. So plenty to go at, but I just wanted to, as there were points that I'd had on my list to raise, Ellen, I wanted to endorse what you'd said. Thank you. Adam.
Thanks, and thanks, Maria. I absolutely agree. It's great to see the 4 places together on the report, and it is the first time we've seen that, and I think there are still things we can learn from each other and do differently as a result of that conversation. 2 points, I think. One is a one is a plea for us to remember, and the second is an ask. In terms of the plea, I know it's referenced in many of the area updates here, but we do need to continue to remember patient and public voice in this, because I think it's probably all too easy to design something that works for health and care providers but may not work for our community. So I think that really needs to be fundamentally at the heart of it. The other ask, really, it's really encouraging to see some focus on the enablers, things like the infrastructure and the estate we've got to deliver this. I know in Warwickshire we've got some really poor community and primary care estate, which really hampers bringing teams together. It's reassuring to hear we've got capital to support that, but I imagine that won't go very far. Have we got the right processes in place to be able to prioritise that?
That's very, I totally agree with your first point. Very good point on the second one, and I might bring Mark in on this one. So obviously we've still got the ICB as work capital programmes in both places, and I know it's slightly different amounts in both areas. I think the individual focus is on trying, because it's got to be spent in a particular time scale as well. So the focus at the moment is how we can upscale neighbourhood health support from a estate's point of view, and I know Roy's been involved in those discussions in this week in Hereford and Worcestershire, and I'm sure in Coventry, Warwickshire, those discussions going on. I'm sure Mark will want to see an overview of all this once it's pulled together as potentials, and then we'll talk about how we prioritise. But we'll do that in partnership with all of you, just to make sure you're all fully involved in that process.
Thanks, Mary. And again, I'd just endorse Adam's point really about patient and public voice, and I was going to maybe link it to a general point, is how are we going to communicate this and make it mean something to the public? I think neighbourhood health has become our conversation. I'm not absolutely convinced people in the public understand what it is, what we mean. And so, there's a danger that we're having a conversation between us on what neighbourhood health is rather than with our public. So one of the things I was going to ask for is something, it's almost like, what would we say? What would any of us say about what we mean by neighbourhood health? I always measure it in terms of like a corridor conversation. If we were having a conversation with any member of the public, what common set of words would we use to describe it? And do we have that? I'm not sure we do, and the paper is excellent as a stock take, but it's very much our stock take, isn't it, from an NHS perspective. So how do we think about the kind of vision for it? And I think there are some really good descriptions in the individual places, but I just wonder what would we want to have a generic view of what neighbourhood health is that we want to share across the cluster? I don't know the answer, Mary and colleagues around the room. I'm sort of proposing this to everyone, but it does feel like, what is that conversation with the public and with our stakeholders, so we all know what we mean by it and it becomes easily understood rather than something that feels again, it's an NHS concept, I suppose, born out of that plan. So, Mary, I don't know if you want to say anything about that, but it just feels like something we need to pick up.
Yeah, I think it's a really, really interesting point and something we do need to reflect on and go away and talk about. I think all our engagement with the public over the last few years, they've talked about complexity of accessing services, be it across health, social care, etc. Repeating their story many times, not enough time to deliver care. So I think some of the principles are there that the public have told us. How we brand this, I think, as a change going forward, I think we need to reflect on how we do that. So we'll take that away.
Thanks, Mary. David.
Thanks very much. And Mary, thanks again for the report. I think it's really helpful and also really encouraging to see what progress has been made in some areas, and that then gives the view or the kind of vision of what actually could be achieved through neighbourhood health. So I think that's really encouraging. I wanted to make a comment on on the discussion around measurement, I think it's really important and really good that we're talking quite a lot about measurement. It would be helpful, I think, also to be more specific and more focused on it, to actually understand not just what impact it's having, but actually to start off with what do we actually want it to achieve. And then I think that can help us to focus the things that we put in place. So that's bringing kind of measurement, almost KPIs up to the fore as we design. And the second question was one from Aman, really, which was about PHM data and whether it actually does, whether the data we have or the data we can collect, whether it does include the hard to capture, difficult to engage populations within our areas.
Okay, thank you. So yeah, I mean, I think the metrics and outcome, I think we've gone through that, and that's work that we need to carry on doing. The PHM, we're in different stages in each part of the cluster at the moment on that. What each place has got available PHM and how they can use it. I think so we're going to standardise some of that across the cluster and support, as I said earlier, the place-based systems to have that information at their fingertips. Really, it should reflect different demographies. It should give that targeted, targeted area that we need to support. Be it a small area that's got high deprivation or homelessness or anything like that, it should give us that information. I think we've got to mature the tools to get us there. I think there's an ongoing piece of work to mature those tools. I think it will give us definitely age profile. It will give us areas of our system that got a high age elderly population. It will give that high children's population. I think it's got to be definitely matured to give us that richness that we need going forward. David might want to come in on that. David Mahaffey, you may know more than I do.
I think it's something up well, Mary. There are two different systems, you're right, across the patch. Primary care has very rich data about its communities, but we don't always have joined up primary and secondary care data, certainly on the Herefordshire and Worcestershire side of the patch, but we do on the Coventry and Warwickshire side of the patch. But there is more development work that we can do. But the intention very much is to have that comprehensive picture of all populations, because in particular we'll be focusing on those who are struggling to access healthcare, because they're the people who often pop up more in the urgent care space. I think Andy was mentioning before that if we can move to scheduled care rather than urgent care, well, PHM is one of the tools that we can use to help us be better at that.
Great, thank you.
Thank you very much. Well, we've got a number more hands up, so I'm going to bring those 6 people in, but I suggest in the interest of time, Mary, we'll just take 2 at a time, so we're not you're not responding to each one after, and we'll try and get through those as quickly as possible. So Siki first, and then Nigel, please.
Thank you, Mary, for the report. I thought it was really comprehensive and sort of gives us insight into what is key for our sustainability, really. On page 56 of the report, you highlight the challenges, and I just wanted to have a feel of which of the identified challenges presents the greatest risk to developing sort of the neighbourhood health at scale, and how does the current pace of sort of the organisational change within the ICB affect our ability to sort of support and enable the programme, particularly across the cluster in a systematic way, whether that's sort of framework, sort of workforce, agreed metrics and so forth.
Thank you, Suki. I'll bring Nigel in, as I said, just to add to his question, and Mary can be thinking about her response. Nigel.
Thank you, Krishni. So I think you stole a little bit of my thunder with the that conversation and that communication with the communities, because I think that's really key to this. We need to have a very clear, because I think a lot of people struggle with the definition of neighbourhood health, and that we cannot expect our communities to have a natural understanding of it and get behind it, which is so important, if we're not really clear on the messaging for that. So I think that is absolutely critical. My second point was about actually a bit of internal reflection for the senior leaders on the call here, in that I think that there's a real important role is making sure that the message about neighbourhood health, and more importantly, the integrated working that is associated with it within our own organisations, because I can see that, you know, leaders perhaps have a good understanding of neighbourhood health. Actually, the impact of working in a different way, in a more integrated way, is quite challenging for some of those delivering services. And actually, I think that conversation internally about neighbourhood health, the priorities and that integrated working is a really important conversation for us all. And that change of working from that organisational focus to that integrated focus is a huge cultural piece.
Thanks, Nigel. I think it might be helpful to think about picking up part, you know, almost following that conversation on at the next session. I think David Mahaffey, I think you might have already thought that might be helpful, but I'll let you think about that. But Mary, do you want to come in on, I think Suki's question was just about the risk, wasn't it? And particularly in the context of organisational change.
Yeah, and I think this does relate to prioritisation, to be honest. The 6 big areas and risks that that we've identified in the report. We need to now look at where we focus first. We've already committed to investment up 3 years out of hospital standard, but you know that does come with everyone buying into that incentive framework and the risks associated to financial frameworks across the system. So that's a big piece of work that we're going to have to focus on and prioritise, I think. And I think the other one is getting the infrastructure in place that was mentioned earlier. So the particularly the IT and the estate to be successful in neighbourhood health, to foster those ways of working. I think if we can focus on those two first of all. I think what Nigel has said about the individual organisations at Place focusing on the organisational development. I think if Place can do that and you know, really buying into neighbourhood health. I think if from an ICB point of view, we've got to discuss this, and ICB across the blue cluster, can we support in those 2 areas would be my priority.
Thanks, Mary, and thank you, Nigel and Suki. Okay, we'll take Eamon and Vivek next. So Eamon, please.
Yeah, could I just please start by just talking about a little bit of history in Coventry. Over 30 years ago, we had a programme which was much less well structured than this one, which was looking to develop something very similar, though, in model. And the patient story that we heard, I sat in integrated primary care team meetings where similar stories were being told over 30 years ago, and it wasn't sustained. It wasn't sustainable. And one of the things I do want to commend this paper. It's a really excellent briefing document, is that it does seem to me that we are putting in place something which is much more likely to be sustainable. That's the first thing. And I think one of the things as a board we need to be thinking about, what is the legacy that we want to leave, and what are the lessons that we want to learn, and building that sustainability is going to be absolutely clear. And everything I've heard from what Maria said about clear view about change model, the points about resourcing, which I think are absolutely critical. In any business, you would have double running costs to make this change happen. So I think a key aspect of this is going to be building sustainability. The question I wanted to raise around my learning from those experiences going back a long time, two key points really. The first one was we had a number of projects. The most successful ones were those that were led by general practice. And we've been quite silent so far on just how pivotal general practice is going to be in this. And I see one of the key objectives is to tackle unwanted variation and access to high quality general practice. And I know from my own experience of working across this whole geography that does differ quite a lot. So I think in terms of making this sustainable across all of our communities, I'd just like us to reflect a little bit on where we think we are with general practice, where that relationship needs to go. I think the second thing, learning from international systems that have made a success of integrated care, the key, and other colleagues have mentioned this, is working outside of organisational boundaries, and that includes our clinicians in secondary care as well. So I think because they provide some of the, as clinicians on the call will know, some of that expert advice in relation to particularly clinical risk management, which is always impacting on clinical practice. So it seems to me that there's a huge challenge for us in terms of making sure all of our communities, which we've talked about, but also our clinical communities are really bought into this. I'm very optimistic because I think this is being built on much sounder foundations than we built the work we were doing 30 years ago. But just some reflections and those questions.
Thanks, Eamon. Mary, I'll just bring Vivek in as well, as I said, in the interest of time. Vivek?
Thanks, Chair. It's just Adam touched on this, and that's about infrastructure. So we know our local authorities have got really large housing targets that they're working towards. So significant population growth. I know there is in Worcestershire because the local authorities engaged with us. We're also getting members of the public engaging with us about, well, how will you meet this kind of population growth from, for example, an ambulance perspective. So some of the population growth anticipated would amount to a whole neighbourhood team. So, for example, in Worcestershire, off the top of my head, I think it was 20,000 houses over a period of time. And I guess that just needs to be built into the planning here, because there's going to be infrastructure required behind it, and as I say, the growth would be the size of a neighbourhood team, perhaps distributed around.
I think we might have lost him.
I think we've lost your sound, Vivek, but I think we got the general gist of that, Mary. So I think Vivek's comment was about population growth and taking that into account, and maybe you could say a bit about just sort of primary care as well, which I think Eamon brought up, and sustainability really, which is fundamentally at the heart of this, isn't it? We don't want this to be another initiative that doesn't survive, I think.
Thank you. Yeah, so interestingly, Eamon, I did something similar in another part of the country about 20 years ago, and again it didn't sustain, and it was led by primary care, and it worked for the period of time it worked exceptionally well, but wasn't sustained. I've often reflected as to why it wasn't sustained. Personal view, we had other changes in the NHS, contracting changes, and there wasn't an embedding of that way of working, and there wasn't good evaluation either. We didn't spend enough time evaluating in that commissioning model to evaluate the benefits and put them into contracts. So I think the commissioning cycle is really important to move us forward, building on this framework. I mean, I'm hoping, and Nigel might be able to help us here, I'm hoping the national framework that we're expecting any day now will help with that primary care role in this. Every partner in neighbourhood health is an equal partner, but primary care are the lead coordinator for their patient population, so they do play the most important part. And I know part of our new cluster arrangements we're starting to discuss is about how we develop primary care and reduce that variation across the system in ways that we've been successful in the past in doing that. So I think it's watch this space on how we can support primary care.
And Mary, anything about population growth that you want to pick up Vivek's point?
It's an ongoing challenge in many fields, isn't it, really? David might want to come in, but in our planning and looking forward, we do it on our big care pathways. We look at the future 10-year population and what do we need to put in place so we are sustainable going forward. But David might want to come in on that one.
David, briefly.
Yeah, thank you. We're just in the process actually of working with our public health colleagues, coordinated from Worcestershire, but across the whole patch, on writing a specification to do some proper modelling of housing growth and impact on population growth. So we'll have a much more comprehensive picture of what that looks like across all 4 geographical areas. Because whilst we're right, 20,000 houses is a lot of houses. What we also know is it doesn't necessarily create new population. It's often dispersal of existing population. So it can be quite a difficult sort of complex analysis to undertake to work out exactly how many additional people we're getting. And just relying on the kind of census data that comes along and then the ONS population updates doesn't really help us with the detailed planning. So we're picking that up, and we will be far better at that in the coming years than we have been in the past.
Okay, thank you, David. Right, so we've got a few more questions, and we'll probably definitely need to draw a line under Paul being the final one because we're running late, and and you won't get a coffee at this rate, but that's okay. I think we can continue for a little bit longer. I'm sure that'll be okay. Gail and then Russell, please.
Thanks, Krishni. And Mary, I just want to echo, I found it a really helpful report, particularly for me coming in as an overview and a starting point. So I'm looking forward to more. I think what it does do is it highlights what a complex and extensive development this is in order to actually get us to a sustained way forward. And I think for me, from my experience, some of that is just remembering it's okay not to have all the answers, sometimes asking the questions, and particularly when we talk about beyond our own organisations, how we engage people early without going with solutions, I think can be really powerful. So I think we should hold sight of that. A bit that I didn't want us to lose either was going back to acknowledging the visibility of children and young people. I mean, if we think about some of the broader challenges, if we look at wider determinants, if we look about young people moving into the workforce, we know there's a bit of an iceberg there in terms of some of what we're dealing with. So on the point about understanding ourselves in order and to understand our populations, to look at how we get it right and those outcomes, at some point, would it be possible to have a bit more of a focus on understanding children and young people, the population
Absolutely.
across the 4 areas, understanding the critical issues, because some of that will also help us in forecasting as we move forward. What is it that we haven't got present that we know as we move forward we're going to have greater challenge with? I find that, for me, given a bit more assurance, I'd find that really helpful. Thank you.
Gail, I couldn't agree more. I think, for the populations, I'm sure across the whole cluster, it's really important because, with what I'm seeing just through the SEND agenda, through the new, the next 10 years are going to be very challenging. There's no doubt about it, from a population outcomes point of view, from a workforce point of view, from caring point of view, that there's going to be many challenges. So I think it would be helpful for us to do the same stock take across children. So that's a good point.
Thank you, Mary. We'll think about. I'm sure we've done a CYP themed focus before, so we need to think about where we can fit that into the agenda, Gail, as part of our forward plan, and perhaps bring that back. So we'll take that away as an action, and it picks up on Mary's point earlier as well, about sort of where do children and young people fit into this, and I do think it's really important, because that's where we will get the biggest benefit from any investment we make, because it's over the life course. So there's some real potential value in that, so we'll certainly have a look at that. Russell and then Christine next, please.
So apologies, Chair, I'm put my hand up because I was told off rightly for putting things in the chat box. But I think this discussion about neighbourhood health is disproportionately important for our next 5 years, whether it's around children or what's happened over the last 5 years is the historic use of primary care as a gatekeeper into the acutes, not because of anything primary care have done, but people are going around it. So for me, we do need an overarching narrative neighbourhood health, where the drive for me is to improve health outcomes by delivering more and more healthcare at home, in the community, in your neighbourhood, and to leave the acutes to do the things only they can do. And secondly, to improve value to the taxpayer, because we're currently delivering too much in the expensive acutes. We don't have the capacity nor the money to do everything that we would like to do, and therefore we need to be straightforward with our citizens and be clear about what we are going to do, where we're going to do it, and then what we decide to prioritise, we aim to do excellently, rather than trying to do a whole lot more and failing at much of it. Vivek's point on population across all of our 4 geographies, the population growth has been enormous and is going to continue to be enormous. the earlier we start to be really straightforward that we can't do everything and we need to prioritise and we need to deliver more preventative care in the neighbourhood, the more honest we are frankly being with our neighbourhoods and ourselves and our staff.
Thanks, Russell. Christine may want to add to that in terms of our conversations with the public, Christine, because I know that was obviously an area of interest for you. Do come in.
Yeah, I appreciate the conversation moved on a bit, but this was relating to an earlier point that Nigel picked up about the public, and our experience is that to date, I don't think it's on the public's radar what neighbourhood health is and what's going on within the NHS, particularly at the moment, which is quite rightly focused on how you make this happen structurally within your workforce. And it's really an offer to say that we want to help you as a Health Watch to shape those messages so that we can communicate them appropriately with what neighbourhood health really means, because at the heart of what it is everything that they've been telling us for many years that they want in terms of coordinated, person-centred and integrated care. So I don't think it's a difficult message to sell, it's what they want. But equally, how do we make sure they're engaged in this process and that it works for them, and we're having that constant dialogue about neighbourhood health with the public. So just to say that as a Health Watch we would support that and help you, and I'm sure my other Health Watch colleagues would agree with that.
Thanks, Christine. Really helpful, and I think that's an offer I think I'm sure we'll want to take up, because it is a conversation we need to have, I think, with the public. Finally, Paul, please, Paul Walker.
Okay, thanks, Christine. Thanks, Mary. Just three quick things from me. Wouldn't want to keep the colleagues between the coffee and listening to me, but just pick up on Nigel's point around kind of partnerships locally and integration across the public sector. I mean, just want to say David Mahaffney's blushes, but he's done a lot of work with myself and Simon with the Herefordshire Chief Executives Group, with the main players across the public sector to kind of get us ingrained in the future through the NHS 10-year plan, and more practically through some recent work that he's done together with colleagues around neighbourhood health and anchor organisations, which is proving well and appreciated by Chief Constable, Chief Fire Officer, Simon and myself. So my thanks to David for doing that, and that sets the tone for colleagues in the organisations about expectations about how we work together, which can only be helpful. Secondly, around housing numbers, I mean, our planning officers at the respective local authorities have got the detail of the numbers, populations. We're working with that data now, so that's easy to get our hands on, David, in terms of making that work. And last but not least, and it would be remiss of you, Christine, not to mention it, children's services in Herefordshire are now good, with leadership and management outstanding, which is a huge step forward from being inadequate in 2022. And I do take every opportunity to celebrate that and make no apology, and to say thank you for your support and challenge over the years. Thank you.
Thank you, Paul. Really, no, we are absolutely happy that you've taken the moment to highlight that. It is important that we celebrate things that are positive as well as discuss the various challenges that we have. So thank you to all the colleagues who've contributed to that. Mary, so I think that's been a really comprehensive discussion, and I'm glad that we've allowed it to continue, because I'm a great believer when people have got a lot to say. This is our first joint board in common together, and it's really important that people have the opportunity to kind of explore these things. But Mary, any final comment from you to close this item for now?
Yeah. No, thank you, Christian. That's been incredibly helpful feedback, and there's some very high-level strategic things we need to go away and consider now, and feedback into the national programme as well. I'm sure, Nigel, we can feed this back collectively into sort of influence that was going on. I think we need to launch this. We've launched it well at the place level. I think we need to launch it now across the cluster with some of those issues that we want to try and resolve, and have a really concrete plan behind to get us there over the next few years. But thank you for your feedback, it's been helpful.
Thank you very much, Mary, and thank you to colleagues who pulled all that together. So, I mean, it seems to me some of the key things that we've talked about are very much around the communication and engagement with the public, the role of the voluntary sector and kind of evaluation, and working across organisational boundaries. And I think going back to something that Pete said, you know, that this is all about, there's a lot of this is about culture, isn't it? And it's for us as leaders in this setting to really encourage and give permission in the nicest possible way for people to work across organisational boundaries and do the right thing for the population. And that's the way that we make some of this more sustainable, which was, I think, Eamon's point. Lots to do. I think a practical action was coming back with the CYP, Children and Young People's Focus, later on. I suspect we'll talk about this a bit more at our development session as well, when we come to that. So just want to thank everybody for their contributions. We're a little bit over time, but that's okay. We'll manage that. We'll pick that back up. So I think we'll reward ourselves with a short break. If we can reconvene at 11:20, and I would suggest that people turn their cameras and mics off in the meantime. And we'll start promptly 11:20. Thank you. Just give everyone a little bit more time to make sure we're back, but we'll start promptly in at 11:20. I think we might have pretty much everybody back, actually. That be fair? Yes, well, it's 11:20 anyway, so we'll restart. Thank you very much, everyone, for coming back promptly. So we do have now a system quality and delivery report. So it's an overview of system performance. Mary, obviously we've touched on a few things that Simon, I think, included within his report, and there were some questions in there. So I'll hand back to you, but perhaps you can focus on the things we haven't already explored, and no doubt there'll be more questions and comments. Over to you, Mary.
Okay, thank you, and I'll bring Kath in at the end to give an overview of any quality issues. So as part of our transition to the cluster, this is our first integrated report, and this will be further developed and refined going forward, so welcome any feedback, that would be helpful. And we maintain the governance until we implement the full new committee governance of the cluster to make sure we don't miss any of the issues that we need to be dealing with. So just on urgent emergency care, just the one thing I'd like to add to what was discussed earlier. Bed occupancy is a key factor for large parts of our system, particularly Hereford and Worcestershire, and reducing bed occupancy has been a challenge which we haven't been able to deliver this winter, and hence the focus on continuing to try and do that to make sure that we have the good flow that we need in urgent care. So that's something that's being highlighted to us regularly by regional and national colleagues. But apart from that, you can see the updates there. I won't touch on elective apart to say that we benchmark extremely well on the 65-week waits in December across the region, across our cluster. We've done really well in reducing that number to a very small number, and we need to continue to sustain that now and move on to the 52-week waits, which, looking at the profiling, we should be able to do. Just to add to the cancer discussion, so the national team are reprofiling the tiering system. For those that don't know, the tiering system is sort of a level of concern about performance nationally, and the support that's provided to systems to rectify that support. So that's being re-evaluated currently nationally, and we anticipate across the cluster we'll have changes in the tiering system, which will inform colleagues of as soon as we know about that as well. So that's just an update on that. Just on the children and young people, and we have picked up a little bit of this in the solution in our early discussion about neighbourhood health, but I just want to stress that one of our biggest risks is the length of wait in community paediatrics, particularly in Worcestershire. We've made real improvements in paediatric therapy services in Worcestershire, but the actual waits for new assessments is very excessive. So we are just formalising agreeing with Ellen and her team a 3-year plan of investment and support to make sure we can reduce those very long waits, and then focus on that neighbourhood health approach to support and do early intervention in that system. So that plan has now come together, which is really helpful. Mental health and learning disabilities, I won't go through the detail, but you can see the areas of focus that we need to resolve. We anticipate the talking therapies will resolve itself in the coming months. We're not too concerned about that. The focus, I believe, will be in Coventry and Warwickshire, where the length of stay in adult mental health and the use of inpatient settings by those with a learning disability is relatively high. So that will be the focus work for improvement going forward. So that's the overview, and you've got the dashboards at the back, which we'll continue to refine and make as user friendly as possible for the board going forward. And happy to hand over to Kath for any updates on quality or anything else to say about quality.
Yeah, many thanks, Mary, and for colleagues. The quality summary is as detailed in the paper, but I'd just like to highlight two pertinent points. You will see within there the ongoing infection prevention and control pressures, which are in line with national increases. And just to let you know, there are robust systems in place and clear improvement actions in place there. And also of note, a limited number of quality risks are currently under enhanced surveillance. This includes enhanced surveillance with the region, as detailed in the paper. Pleasingly, there are clear recovery plans in place, external assurance, and there is a trajectory of improvement on those quality risks. Thank you. That's all I would like to say.
Thank you very much, Mary and Kath. David, please.
Yeah, thank you very much. Two questions actually, Mary, on children and young people. One is that we focused there on Herefordshire and Worcestershire, and something we've looked at in Hereford and Worcestershire for quite a long time, but there's no mention of Coventry and Warwickshire. Is the situation much better in Coventry and Warwickshire, and indeed kind of in line with expectations? There's the first question. And the second question is one from Aman, which is to question how confident are we that the long waits in paediatric therapy services will be eradicated by Q4? And you mentioned the plan just now, that plan is coming together. When will that plan be delivered or be completed, please?
Okay, so thank you, David. My early view on Coventry and Warwickshire, the very long waits that we see in Worcestershire, that's not evident in Coventry and Warwickshire. There is increasing demand, as there is across the whole country, to be honest. So there is a pressure there, but not the extent that the very long waits that we've seen in Worcestershire. It seems like it's much on a par with Herefordshire, which is pleasing. Still lots to do, but it doesn't look as very long waits as we've seen before in that Coventry in Worcestershire. So that is being dealt with. The 3-year plan is due to be commenced for delivery starting from April. So we've already in this year, just a reminder, so right to choose. So through the right to choose, the population and GPs can refer children and families to independent providers for assessment. We've put quite a lot of resource into that this year. Going forward next year, we will continue to do that and invest in other services within the Health and Care Trust. But it'll be a 3-year programme, but to bring the waiting list down to benchmark acceptable levels. But the first year focus has to be continuing those very long waits, particularly those waiting over 2 years for an assessment. That's really, really important that we resolve that quite quickly. And we've been successful in Herefordshire doing that, so we want to do that in Worcestershire very quickly.
Thanks. And are we still confident that we'll be eradicating the long waits by Q4 that we had said before?
Yeah, for therapies, yeah, there was one issue with occupational therapy, and thankfully the council through the joint commissioning arrangements have resolved that issue. So we're very confident on the therapies sustaining their position. It's the initial assessment through the paediatricians that is the issue.
Great, thanks, Mary.
Yeah.
Thank you, David. Adam, please.
Thanks. Yeah, I just want to raise a question about demand management. So elective and cancer performance. We touched earlier with cancer on the increase in referral numbers that we've seen or that have been seen in Herefordshire and Worcestershire. And that's also certainly true in Coventry and Warwickshire. And we've done a bit of work on demand management and working with practices where we've seen those patterns in the past. But this is a continuing problem, and I think potentially an increasing problem. Just a comment really, that it feels like there's a system piece of work we need to do on demand management to understand that and address some of the challenges. The elective targets in particular for next year, well, they were tough this year. Next year they're even tougher, and I think without that piece of the jigsaw we won't make them.
Yeah, and Adam, totally agree on that one. I mean, those targets for elective, are eye-watering, aren't they, to be achieved? So we do want to start to talk to you about how potentially as a cluster we come together to discuss those big issues, and demand management being one of them, and what we can do across the cluster to support that. So really welcome the comments, and something we'll take forward, definitely.
Thank you, Adam, and thanks for the response, Mary. Vicky?
Thanks, Mary. Just a question about the 65-week waits in the cancer section. And what I was wondering is, are these the same specialties across the cluster, or are they a variety of different specialties? Because you reference, obviously, the independent sector and mutual aid. and just understanding what the pattern is that's coming across there, and I'll follow up with another question if I may.
Yeah, there are some similarities, but there are some differences as well, and Rachel might want to come in on this. There are some specifics to each area, but there are some. Dermatology is a challenge, I think, across the country. ENT is a challenge across the country. I know the region are trying to pull people together to discuss these issues. Dermatology, I'm sure, is a challenge in Coventry and Warwickshire as well because of demand, but for Hereford and Worcestershire, it's a specific fragile services. So we are still scoping all of that out, Vicky, and we'll make that clear through the fragile services work going forward.
Lovely. Thank you for that. And I guess the other question was on learning disabilities, and within the paper, Mary, you reference the percentage of inpatients with a learning disability, and that's for Coventry and Warwick, but there aren't any figures for Hereford and Worcester. So is that because there are none, or what? I was left unsure about what the comparison was across both areas.
I haven't got that number in front of me, but I know it is very low. Kath might want to come in on this. She leads the Kath might want to come on this.
Yeah, I'll come in. Thanks very much. Yes, we are below trajectory and perform really well in Herefordshire, and Worcestershire slightly more challenged in Coventry and Warwickshire. So we've got 16 in Herefordshire and Worcestershire and 0 children.
Brilliant. Thank you very much. That's helpful.
Thanks, Kath. Mary, please.
I'm just going to try and help you out there, Kath, in terms of the question around the LDA for children. So the organisation saw a spike in children who needed admissions over October, November. We've got a trajectory that's really clear that we'll be able to reduce that back to the planning numbers. And that's being overseen at the LDA Collaborative Forum, which is a system-wide forum. So some confidence that those numbers will come down by end of Q4.
That's helpful.
Great, thank you very much. Actually, can I, it wouldn't do for me to go through a meeting without asking a question about mental health. I don't know whether Mary or Ellen want to comment, just really about any system challenges around the acute adult average length of stay, and whether, I know that there's a reference to improvements to inpatient care, which is mentioned in relation to Herefordshire and Worcestershire, but I just wondered if there's anything that we collectively need to do to support a reduction in that. Mary, I don't know if you want to comment on that.
Thank you, Chair. So you might have seen in some of the reports, we've got a 0 out of area for adults needing an adult acute bed or a psychiatric intensive care bed. 0 position for the last nearly 2 years. Back to my earlier point around data quality and the new EPR. So because of coding and duplicate records at the reporting period, there were 4 people there who should have been taken off the list, so they contributed to that spike in the length of stay. The data has been cleansed. We're back to where we started off, which is about 50 odd days. So I think it talks to my earlier point around the frustrations with our EPR and not being able to reflect the reality on the ground.
Great, thank you very much, Mary. Helpful to clarify that. Ellen?
Yeah, I mean, slightly different for us. I would say, I mean, overall, as you can see by the kind of rank, we're nearly top 10 in regard to this metric, and we do also have a very low rate of beds per head of population in Herefordshire and Worcestershire, which people will be aware of. So we are using bedded care at a much lower level than some other systems, and our length of stay is performing pretty well, although we did set ourselves obviously very ambitious targets in this regard. So a couple of things we are doing in this space are around extending our bed management to 7 days a week. So that's been a pilot, and it has shown real benefits, upping the rate of the kind of board round, ward round, etc. We still experience delays around discharge, particularly for housing for people who fall into this cohort, and unsuitable ongoing placements where those are required. So some of those challenges are in the kind of partnership space around discharge planning. But I'm confident we can continue to deliver improvement with our 7-day-a-week bed management processes. And similarly to Mary, some really strong performance on out of area as well, i.e. we haven't had any for a long time.
That's very positive, and because it's a big focus, isn't it? Thank you, Ellen, really helpful. Appreciate both of your comments. So Mary, I think you want us to note that report. There's nothing to particularly approve, but always useful, I think, to reflect on system delivery and quality, I think, for members of the public to be aware of some of the concerns and issues we're managing at the moment. So we'll note that, thank you. We move on then to, well, actually, Mary, if I can make a brief comment about the report. You were just talking before I hand over to Mark. I wonder whether, just linking to my earlier comment about the NOF ratings, where one of those measures is a NOF measure, I think it'd be useful just to signal that, so that we're really, again, it just allows people to be really clear, you know, where there's performance is clearly off, and it's a NOF measure, it's contributing to the NOF rating of the relevant organisation. I think that would be relatively straightforward.
It will do.
Great.
Okay, thank you, will do.
Thank you. Okay, over to Mark then for the financial plan and delivery for 25-26. Mark?
Thank you, Chair. Good morning, colleagues. So the paper you've got today provides updates on both the year-to-date position for 25-26 and the forecast still for the current financial year. You'll see within the report there's two sections, one that covers the Hereford and Worcester side and the other that covers the Coventry and Warwickshire side. We've also in the appendices put a bit of an update in around medium-term planning. I wasn't going to go into that today, colleagues. We gave an update at the last board development session, and I know we've touched on some of it in some of the previous updates in terms of where we are on that. There is still a lot of work to do on planning, and those conversations are live at the moment with colleagues. So just on 25-26 then, the paper covers as at month 8, which is November, but since the paper was produced, we've now got the month 9 numbers, which covers December. So I'll give a little bit of an update on month 9 and where some of the key areas of challenge are at the moment. So if I just touch on month 9, then at month 9, the overall position has deteriorated across the cluster by another 1.6 million. So we are adverse to plan now collectively around 8.8 million. The deterioration we have seen is predominantly on the Hereford and Worcestershire side, which is 5.2 million behind plan, but that's been offset by the Coventry and Warwickshire side, which we have seen an improvement at month 9. It's still behind plan, so 3.6 million behind plan, but we have seen an improvement in that area. So if I just touch on the specifics then within each part of the cluster. So from a Herefordshire and Worcestershire perspective, the overall deterioration has been we've deteriorated by 2.1 million from plan. So we're now 5.2 million off plan in Hereford and Worcester. The deterioration is all within the Worcestershire Acute Hospitals NHS Trust, which we've seen a movement from being 6.1 million off plan at month 8 to now 9.7. The main driver is around the efficiency delivery, which at month 9 is 8.8 million pounds off plan. There is a financial recovery plan that's been developed by the Trust. It's a live financial recovery plan and is subject to oversight by NHS England from a regional level. There is risk within that financial recovery plan, and we're working through that very closely with the Trust to understand that risk and look at what more can be done to support the Trust in mitigating that, and work out then where that's going to leave the Trust as we get closer to the year end. It is just worth saying, as a result of that deterioration in the financial plan, NHS England have taken the decision to withhold Q4 deficit support cash. So that's £18.3 million that's been withheld at the moment for the last quarter. That has implications not only for Worcestershire Acute, but also for Wye Valley, because deficit support is withheld from the system, not the individual trusts. So again, subject to working and assuring NHS England around the recovery plan, we're hoping then as we get closer to month 10 that deficit support is reinstated, because that is giving some cash flow challenges to the two trusts that we're having to work through at the moment. It is also worth flagging, whilst we're working through this recovery plan, as we get closer to month 10, if we're in a position where we can't get the trust back to a balanced position and that can't be covered or offset by system partners, that will have implications as we go into 26-27, as all deficits then becomes repayable under the current NHS England business rules. So it's imperative really that we pull out all the stops to get back to that balanced position this year and not carry any of that debt and repayment into the new financial year. Just touching on the other trusts then, so other trusts within Herefordshire and Worcestershire are on plan or slightly ahead of plan. It's not without risk, but they're all continuing to forecast delivery of their plan at the moment. And as you'll see in the paper, capital from a Hereford and Worcester perspective is slightly from a year-to-date perspective behind where we need it to be, but we are still continue to forecast delivery, and we're closely monitoring that with NHS England. I'll just pick up on the CW side and then come in for questions. So again, we have seen an improvement. So it's a £1.5 million improvement between month 8 and month 9. So the plan was £5.1 million off where it needed to be. It's now down to £3.6 million. The improvement we've seen is within George Eliot. So there's a £1 million improvement we've seen there year to date, and £500,000 within South Warwickshire. I think what I would say is, whilst the improvement is welcome, South Warwickshire is still behind plan, so it's £3.7 million behind plan. There's a number of factors behind that: increased staffing in A&E we've seen as a result of the CQC inspection and operational pressures. We are now working very closely with South Warwickshire to understand what actions have been put in place to turn around that the run rate we're seeing in the trust there, and understand then where that's going to leave the trust as we get closer towards year end, noting that we've got about 2 months to go between now and the end of March. We'll be reviewing this again at month 10, and again, similar to the Herefordshire and Worcestershire side, if we cannot cover that collectively as a system, that will give us a challenge as we go into 26-27. In terms of other partners within the system, then they're on plan or slightly ahead in terms of what they're reporting at this point. Again, not without challenges and pressures there, and again, they are still all delivering at this stage and signalling that they will deliver their financial plan. Just finally then, just picking up on capital, so at month 8 the capital position is behind, so we're behind about 15.5 million. There are a number of different drivers behind that, which we've touched on within the report. The system is still continuing to forecast delivery of the capital plan, and we are working very closely with trusts and with NHS England to ensure that all resources are managed and are utilised in line with the plans. So I'll stop there, Chair. There's a lot of detail within the reports. We've tried to make sure we cover everything across both parts of the cluster and for the individual systems. But happy to take any questions or comments at that stage, Chair.
Thank you, Mark. Russell, please.
Just a couple of things from me. The first is to thank Simon for appointing Mark to the role of Chief Finance Officer of the cluster, because I think that would certainly help with some of the discussions across both ICBs to address the challenges we're facing. This is undeniably sort of squeaky bottom time in terms of the finances, but I know that the teams are working in a very mature way. It's probably worth me just noting that Neil Cook, the Chief Finance Officer for Worcestershire Acute, has left the organisation. I thank Neil for his hard work, but recognise that Katie Osmond, Chief Finance Officer for Wye Valley, is taking on the shared responsibilities for Worcestershire Acute. Katie Osmond used to be Deputy CFO at Worcester. She's very well known to a number of members of the board, and I'm sure as we enter into 26-27 planning, the level of debate and transparency will be improved as a result of that change.
Thank you, Russell. Chris, please.
Thank you. We touched on earlier the importance of having a good understanding of system risk. And I just wonder, in the interest of that, probably too late for this year, but I'll pick it up with Mark. I wonder if it may be helpful for us to have an additional metric, which is about the sort of implied average monthly reduction in run rate, if you use that complicated sentence. But in terms of delivering the plans and the forecasts of the organisation, obviously there's the last quarter in this year was quite a challenge, as Russell had just indicated, for everybody. And but there's also a differential challenge in there as well. It's probably helpful for us just to understand the total picture and then the differential challenge as we move forward next year. So I can pick that up with Mark. But
Okay, thank you, Chris. David.
Thanks, Krishna, and thanks, Mark. That was a really clear presentation of the situation we're in. Thanks very much. A couple of questions. One is really from Aman and one from myself. We talked about the DSF, the support from NHSE. Do we have, I think you referred to it, but do we have plans in place to make sure that Wye Valley is protected, the cash flow there is not going to be impacted by the withholding of the funding from NHSE, is the first question. And second, may well be already covered by what Russell said about changes in personnel. But I do remember that at the last board meeting, we were going through and we were, asking for assurance that processes were in place to ensure that the recovery plans were firm, and that I think that we're going to maintain grip and control over that. Has there been something particular which has happened to make that more difficult for us over the last 2 months?
Thank you, David. So a couple of good questions there. Whether Stephen will want to comment specifically on the Worcester Acute Recovery Plan. We did have a session last week at the Hereford and Worcestershire Finance Committee, just going through that to understand some of the pieces within there and what needed to happen. I think it was flagged at that point, it's not without risk. We just need to work out how we try and mitigate that risk and try and manage it down as quickly as we can. But there is a lot within that recovery plan that needs to happen. Just specifically then in relation to Wye Valley. So Wye Valley are impacted as a trust as a result of the deficit support being withheld. So it will give them some cash flow challenges. We are looking at all options within the system and within the allowed rules to how we can support them from a cash perspective, to ensure that basically they don't run out of cash. So we are monitoring very closely and working through and ensuring that there is nothing outstanding between us that can be paid quickly to ensure cash flow is managed and maintained.
Thank you.
Thanks, Mark. Stephen, do you want to add anything on the recovery aspects?
I'll probably just say, yeah, we've been back through all of the recovery elements. The main majority of the CPIP is on, and particularly around the banking agency reduction, things like that. The areas that we've struggled a bit are, there were some assumptions around capacity coming out, and particularly if you put that to where we are with what we've experienced through winter, that's been a bit harder to transact. The bit I would say to kind of give some assurance to the committee and others is actually we're on the right lines with it. We would definitely get that over the line in next year. So there was a bit we were doing together with system partners in Worcestershire around how we move out the expensive bits and move that through. I think we're still doing the right thing. It's just not transacted itself in the right time. The other bit that there's two other bits that I think are helpful for consideration that'll be we're just exploring, but will definitely hopefully land us this year, but will definitely get us in next year better shape with KT being over the two. One is a consistent approach to more of the technical accounting side, and there's definitely avenues we're exploring around that. Some kind of short-term, non-recurrent, but others is a much more consistent approach between the two trusts. And the other is, with that, it also helps us with regard how we can manage different things like activity flows or some of those funding streams between the two trusts. Whereas traditionally, if you had two separate organisations, you'd be a bit worried about doing some of that. Speaking in a bit of code, but you'll work it out. With one finance officer over, we can maximise our flexibility for both trusts to do that, and particularly when we go into the planning round. But we've refreshed all the recovery plan, we've refreshed all the arrangements around it just to make sure that we are absolutely all over it and doing the right thing. It feels a lot clearer. So I feel, you know, this year is going to be difficult. There's a lot of risk in there, but actually, if I take a bit of a longer look, I think we're in a much better shape.
Thank you, Stephen. I think really, you know, it's as Mark has said, obviously, and Stephen and others have commented that, you know, there's obviously a lot of work going on at the moment to recover the position. There is just something about the learning for next year, isn't there? And just making sure that. And it's not actually just next year. I think it's just there is something for us collectively, and hopefully the opportunity will come with. I know Mark and Rachel are kind of planning a workshop as well with CFOs, which is referenced in the documentation around cluster governance. But for all of us, as part of our planning, it's really important that the strategy is you know, the building a sustainable future is transformation and financial sustainability all looped in together, because these aren't separate things, and I think we all recognise that. And that we see, you know, the planning as multi-year and delivery in productivity as multi-year, because actually a one-year horizon is never going to kind of deliver on this, I don't think. So there's just a reflection really, I think, on making sure that in our approach going forward, we're building that long-term thinking so that we're not running to deliver in years, you know, CPIP, which it just doesn't kind of work really. It hasn't worked for a very long time, and I think it just makes the life difficult, and especially if it's profiled in the back ends of years to deliver. So there's something about rolling programs of work and rolling programs of transformation that also enable financial sustainability, and easy to say but hard to do. But everything we need to work towards together, I think, feels important for us to deliver on that. Russell?
Yeah, just to reinforce that, Krishni, I mean, we do need to, we're all victims of the hemorrhaging of the expensive acutes, and therefore we need to use the acutes less and do everything in our power, like I popped into the chat box, to change demand patterns. So only those patients that really need to come to the A&D come to the A&D. We still see too many people coming to the A&D who don't need to be there, and then for safe staffing and everything else, that is extremely expensive for us to cover. But the more as a system we focus on using the acutes only for those things that acutes should do, the more financially sustainable we will be. The less we focus on that issue, the longer this problem will endure.
Thank you, Russell, and it takes us full circle to kind of making sure we get neighbourhood health right and sustainable, doesn't it? So it's all connected, as we've said earlier, but really important that we get that right. So thank you for that. Mark, any final comment, or are you happy to close on that?
Happy to close on that, Chair.
Great, thank you, Mark. Okay, finally then, we move on to some governance and assurance updates. I think Hannah always manages to pull some time back on these, so I think we'll be all right for hopefully for finishing still reasonably on time. But item 12 is a governance update, Hannah. So do you want to draw any attention to any particular aspects of that?
Thank you, Krishni. Yeah, just really briefly, so this is an update on cluster governance arrangements, which is a bit of a continuation of the conversation we had in both boards back in November. So firstly, just to point out that the constitutions of both ICBs have been approved by NHS England, which largely contain changes to board membership and the way both boards will be working together going forward. And then there is a summary of committee arrangements and committee chairing arrangements in particular on page 2. And what I wanted to pull out in particular is Strategic Commissioning Committee terms of reference, which we are bringing today to both boards for approval. And we've already touched upon Finance Committee and partially on the Integrated Quality, Performance and Assurance Committee, which will both be new joint committee, which should be operational from the end of Q4 of this business year or early in Q1 of the following year. And then just finally, that scheme of reservation and delegation and standing financial instructions we haven't forgotten, but there is a bit of an order of doing these things. And once committee arrangements are clear, we can then finalise the rest of the governance arrangements. So that's all I wanted to pull out. So I'm just seeking approval today for the Strategic Commissioning Committee terms of reference, please.
Thank you, Hannah. Any comments or questions about that before we conclude that? Hannah, just a brief one from me. It's not to say that it's not reflected in there. I think Strategic Commissioning Committee is noted as being, I think, the role for making decommissioning decisions. But it was just really being almost more a kind of general comment about it, was that we do need a common approach. And I think at the moment, obviously, Coventry and Warwickshire, I think, makes those decisions through finance and performance, and that's sort of different. So I just wanted to be clear whether finance and performance is now effectively not happening, because that's not mentioned as we're stepping that down. So just wanted to be clear about that. And make sure we are picking up a sort of joint approach around decommissioning decisions, because I think that's going to be really important. The only other element that I wondered, and it may be one for the committee to look at, Ellen brought it up when we were talking about neighbourhood health, but I think an important role of, well, an important part of the strategic commissioning cycle is evaluation and monitoring. And I think we need to be really clear what the sort of formal evaluation of contract and commissioning decisions fits. And I'm not sure it's absolutely clear in that terms of reference. So I'm happy, I think, that we approve it, but I think we should just review that just to make sure that part we're really clear about. Hannah, back to you on those 2 points.
Yes. Thank you, Krishni. So firstly, on the kind of differences in the two ICBs with regards to approach of approving commissioning and decommissioning decisions. So the report that came to both boards in November sort of set out some of the transitional arrangements, but essentially all of the commissioning and decommissioning aspects will be moving from current arrangements into Joint Strategic Commissioning Committee. The Finance and Performance Committee that you referenced, Krishni, in Coventry and Warwickshire, has been stood down and replaced by a joint system finance committee, which is the one that Mark is talking to the other DOFs about shortly, and also by the Integrated Quality, Performance and Assurance Committee, which will monitor the aspects of performance, which was previously sat in the Finance and Performance Committee in Coventry and Warwickshire. So all of those kind of components have been picked up. So the new committee structure will be dealing with all those elements. In terms of evaluating and monitoring, I think that's a really interesting point. I think there is an acknowledgement that the Strategic Commissioning Committee will evolve over time from a more transactional, tactical commissioning to a more strategic commissioning, which will fully need to take into account evaluation, as you say. And I think I think it would not surprise me if we are bringing these terms of reference back to the board for review, in a few months' time, because it is clearly will be a strategic area of focus, and a lot of development will be happening there under Gail's leadership. So yes, thank you. Acknowledged. Good point.
Thank you. Okay, so if colleagues are happy, we'll approve the terms of reference as they are. I think, as colleagues have said before, I think we need to be pragmatic and recognise that there's stages to a lot of these things. So we'll approve what we've got at the moment, but take the opportunity to just review where evaluation comes into it, and certainly just important to note the changes to the committee structures to make sure everybody understands what's continuing and what's not. Thank you, Hannah. So we approve that and note the rest of the work programme. We then have committee escalation and assurance reports for Coventry and Warwickshire and Herefordshire and Worcestershire as two separate reports. Obviously taking into account the existing committee arrangements. Hannah, do you want to highlight anything in terms of Coventry and Warwickshire in the first instance?
Yeah, I mean, if that's okay, Chair, I was going to take both reports kind of concurrently. So
okay.
Both of these reports are kind of for information and assurance about committee operation in both ICBs. So this will be at the next board meeting in common in March. We will present a single report covering the operation of any residual committees which will be stepping down in each ICB, but also of the newly set up joint committee. So this is the last time we're reporting in these kind of separate ways, and that's again purely practical because obviously those meetings have largely already happened. So wasn't going to pull out anything in particular from either report, but of course we do have committee chairs here, most of the committee chairs here, so if there's anything specific they would like to pull out, they would be very welcome to do so.
Thank you, Hannah. Any committee chairs want to comment on anything within their reports? No, don't feel like you need to, but I did want to pull out something myself. The finance ledger, Mark, I happened to go to the finance and performance committee that Suki chaired extremely well back in, I think, was it November or December, Suki? I can't remember now, but there was a conversation there about the new system and the effect it had had in Coventry and Warwickshire and the problems it had created, Mark. And I noticed we've got a new risk around a finance system. I'm assuming that's the same thing, but I just wondered whether we're happy that it's not limiting our ability to do what we need to do, because there did seem to be quite a lot of anxiety about it, certainly in Coventry and Warwickshire.
Thank you, Chair. So yes, we have got a new finance system that's gone live in all ICBs. It's an NHS England implemented system, so it's referred to as ISFE 2. It has had some challenges, I think it's fair to say, when it's been implemented, and that has caused some issues in terms of how we've continued to process invoices, pay suppliers, and continue to generally be assured from a finance perspective around our overall accounting ledgers. We have found some workarounds to it. There has been a lot of national support and attention put on fixing a number of those issues. So whilst it's not stopping us doing what we need to do, it has added some additional layers and some challenges. We flagged it as a risk because potentially it may get picked up by our external auditors when they do their interim audit and also our year-end audit, because they have to place reliance on the system. So it is a risk. It's something we are continuing to monitor very closely. I'm sure we'll have the conversation at audit committee specifically about it and how we're going to continue to move it forward. But yes, it's still a challenge, Chair. Not as much of a challenge as it was a few months ago, but it's still a challenge as of today.
Thank you, Mark. So if there's no further comment, I think both of those reports, item 13 and 14, the escalation reports are for noting. And I think, Hannah, you were saying that they'll come together. There'll be a joint report coming at the next meeting in March. So thank you, we note that. And then finally, we have the ICB Board Assurance Framework update. So back to you on that, Hannah, please.
Okay, thank you. So at present, the two ICBs have a slightly different approach to their board assurance framework reporting. Both are really robust. They're just slightly different, with the Herefordshire and Worcestershire approach being more assurance-based and the Coventry and Warwickshire approach being more centred around strategic risks. So going forward, again, similarly to the committee reporting, the intention is very much to provide a single cluster-wide board assurance framework based on the newly agreed set of objectives and priorities, which will follow on from the board February board development session. So the intention always is with this document for it to be really quite meaningful and to wrap itself around all the deliverables and our key priorities, and to sort of accurately reporting any shifts in assurance across the year. But for this report, in the meantime, so this report provides an update on the two individual board assurance frameworks. So for Herefordshire and Worcestershire on page 3, there is a dashboard summary of objectives, priorities and corresponding assurance levels, and a visual summary of risk distribution at the bottom of the page. So you can see there are a couple of positive assurance movements there. And then pages 4 to 6 then set out the changes of assurance for individual success measures, which are kind of the units below the building blocks for individual priorities. Page 7 provides a short summary setting out the main challenges likely to prevent us from reaching our target assurance levels by year end. And some of these have already been discussed as part of previous agenda items, so I will not go into them again. And then finally, page 8 contains the detail with regards to individual risk score moves. So then for Coventry and Warwickshire, as previously mentioned, the approach is based on identification and management of strategic risks. So there's a summary of identified strategic risk scores and alignment to corporate objectives, as well as the risk heat map, which is set out on pages 10 and 11. And risk updates are then detailed on pages 13 and 14 of the report. And both detailed BAFs are then enclosed as separate appendices to this report. So I'm happy to pick up any specific questions. As I say, it's a little bit disjointed for this board meeting, but it should all come nicely together going forward, certainly from reporting in May, once the objectives and priorities have been agreed by the boards in common in March. Happy to answer any questions, possibly drawing in other executive colleagues as well.
Thank you, Hannah. Ellen, please.
Just a quick one, really, and thanks, Hannah. Appreciate what a lot of work it must have been to pull all of this together. But I just wanted to reflect on the fact that as you go through the report, there is a consistent theme, isn't there, about children and young people? So we've picked this up earlier, and I think it's right that we do flag that we need a deep dive. I'm obviously aware of some of my parts of that and the work we're doing on the joint plans, so we'll have to think of the timing of that. But the story isn't great if you look across physical health, mental health, SEND, also substantial financial pressures from right to choose. So I think when you see all of it together here in the round, the risk assurance level around a number of these items is marked as limited assurance, which is another thing just to be aware of as a board. So that just stood out to me when looking at this report in the round, and I think just reinforces the point we made earlier at the board about the need for a deep dive. Thank you.
Thank you. And I think it's probably even more relevant because it is literally multi-partner, isn't it? Everything to do with children and young people involves every partner, including schools who we don't traditionally think of providers, but they really are in terms of the context of children and young people. So yeah, absolutely, Ellen, and thank you for highlighting that. But it does really resonate, that point, I think. David.
Yes, thanks, Krishni. I had a very detailed question from Aman about risk 4B, about different percentages stated for people smoking at delivery for Worcester Acute and Wye Valley. There look to be two different percentages there, and I wondered if we could have some clarification on that. I think that one for David Mahaffey, I think.
David?
Yeah, thank you. Very well spotted by Aman. It's actually just a mistake in the report that we didn't pick up in the final read. In one column, it's the September numbers. In the next column, we'd updated the numbers to October. And because of the relatively small numbers of people who are smoking, ladies who are smoking at the time of delivery, the percentages can change quite dramatically, even though they are shown as year to date. So column 3 is the more accurate up-to-date figure based on the October numbers.
Great, thanks.
Thank you. Any executive colleagues want to comment on any particular risks that are highlighted here? You don't have to, but I just take the opportunity if anyone wants to come in. Okay, so I suppose the only question I have really is we've got technically a quarter, 1/4 of the year remaining. Just wondered whether we want to think about whether we anticipate any changes to assurance, positive or negative, over the coming months in terms of Herefordshire and Worcestershire, and any risk score changes for Coventry and Warwickshire, taking account the different approaches. So is there anything that we should be, I mean, clearly finances are, kind of clearly in this last quarter going to warrant a significant focus. But are there any other areas that as a board we should be thinking about now and recognising that we'll need to be sort of on the basis of no surprises by the time we get to March and certainly May? Anything that anyone wants to comment on? Simon?
Yeah, thanks, Christine. I mean, a couple of things. I think the finances, we get into that stage of the year where actually it doesn't all stop at the end of March. So we'll be looking to take actions which drive us towards delivery of the collective financial obligations at the end of year, but at the same time kind of agree financial arrangements for the new year. So we'll end up trying to find a path which ticks both of those boxes. I think the assurance framework reflects that. I'm not aware of any significant changes in direction of travel, and as Mark and various others have described with the money, our aim is to deliver the commitments that we've all made and to help each other deliver the commitments that we've all made financially. I think the second bit, we just reflecting, we've had a lot of comments on children's services, haven't we, or in various items. It might just be worth, Hannah, we'll have a conversation about whether the objectives in the board assurance framework and the assurance are appropriately reflecting some of those concerns, but we can do that probably outside of the meeting and just take stock a bit and make sure we've captured all of that.
Thank you, Simon. That's really helpful. Chris?
Thanks. Yeah, I mean, one, to echo Simon's point that it's really important that we ignore year ends in terms of our planning, because although years have a significance, in some respects, if you're looking at things from a run rate perspective, it costs you so much to run your organisation, and that carries on unless you do something about it, so it is important that we look at it that way. My main point was that we will need to go through a process of harmonising our assessment of risk across the two organisations. That's something we'll want to do thoughtfully, not rush to and do it in a formulaic way, and the audit committee will have a role in that. So we may find some scores change over time due to our approach, because if you run into the ED every day and say major incident, after 3 days nothing happens, it makes no difference. So having lots of reds for a board, although it feels uncomfortable, it doesn't necessarily, it's not of utility to us in terms of allocating our own time and attention and focus. So we will want to be assured that we've taken time to look at the relative risks across the organisations and moderate them if necessary, harmonise them. So I think that'll be a process for the coming year, really.
Thank you, Chris. Okay, Hannah, do you want to make a final comment?
Yeah, I think in terms of the no surprises and any further shifts in assurance. So I don't expect any to go down. I do think because quite a few of our success measures have moved up. They haven't yet amounted to the priorities, going up in assurance rating. But having spoken to a number of the leads, I know we will have some more positive moves by year end, which is positive. But obviously, that's not taking anything away from our really significant risks, including children, which are likely to end below our target levels. And absolutely the points, Chris, about risks, fully agree. Audit Committee will have a key role, and the setting of the risk appetite for the whole cluster. The next board development session will be the starting point for that.
Great, thank you. Well, that always enjoy allowing conversations earlier on, because Hannah always delivers on kind of making sure the governance bit at the end, important though it is. Mostly it's because we've talked about some of these risks and issues earlier through the conversation. So we've happily arrived at about the time that we were actually due to finish on the agenda. I just want to say thank you really to everybody for all their contributions. I'm not sure we fixed anything, but I know we have explored and considered quite a lot of significant issues that we I think have a collective sense of energy to address, which is really important. I did want to finish on a positive point in that there is now a new set of NHS Excellence Awards which have been announced, and the region are encouraging to put for organisations to put themselves forward. I do think it's really, I know these things can be time consuming, but I think it's really important to celebrate achievements that we have made, because I think it helps to build confidence amongst our staff that we are doing some good things, albeit we've always got challenges we need to address. So I really would like us to think about, as a cluster, encouraging each other to put forward some initiatives to that Excellence Awards, which I think are short. The deadline for is March, so we've got some 6 weeks or so, or to get some thoughts around that. So I just wanted to highlight that. But otherwise, thank you very much everyone for contributions. Really good to get our first board, formally board in common, off the ground. We'll see you in February for our informal development session. Thanks everybody.